Good morning. Good morning, everyone. If you can please take a seat, we'll go ahead and get started here soon. If someone can please close the doors behind us. Okay. Good morning, everyone. Thank you all for being here today. I know many of you are driving across the Metroplex, so I hope you didn't get caught by the train. But thank you so much. We appreciate all of your time and for registering for this wonderful event. My name is Leslie Reyna. I'm the Assistant Director of Strategy and Outreach for Safer Care Texas, slash Asthma 411. So again, thank you all for being here today. So I want to start, of course, with some things to know, some things that I bet you all first think about when you come to a conference. Restrooms. The restrooms are right down the hall. They will be right to your left. And then we will have the lunch location. I know many of you saw the breakfast, so it will be around those same tables back there. And then we are being recorded, if you didn't know. So you can say hello to our virtual audience. You can wave at them as they're all watching this right now. So we will have a virtual audience, so please keep in mind this is being recorded. If you don't want to be on camera, I would suggest the far outer corners of this room. But you all look lovely today, so that won't be an issue. Please be mindful of the microphones in front of you. I don't believe we have these tables set up here for our speakers. So please make sure you don't touch that little person, right? The little man speaking in front of you, because that will set off the microphones and everyone online can also hear you. I want to take this moment, of course, to please ask you to scan the agenda if you haven't already. That way you can keep up with the events and what's coming up next, and also when lunch will be, because I know that's in everyone's mind right now. Okay. And give everyone some time to scan. And then, of course, if you don't have the password for the Wi-Fi, this is the password. Speed Rangers with an exclamation point. And then lastly, I want to thank our wonderful partners. Thank you all for all of your dedication and hard work on coming to putting this all together. We appreciate you all. And then I want to start by officially welcoming you all to this conference today. So I would like to introduce Dr. Leslie Alsop, which is our Asthma 411 faculty partner.
So good morning, everyone. Can you hear me? I've got my mic and the little guy, the right button there. I am so delighted to welcome each person who is here today at our inaugural North Central Texas Asthma Summit. And as we consider these topics today, I want to start with some of the good news and the strengths that we have to build on. We know that our region has superb medical services, data expertise, innovative interventions that are brought to us by community leaders who are committed, and you'll hear from many of those people today. We also know that our overall adverse outcomes for asthma have trended downward over the last decade. Yet at the same time, we know that the burden of pediatric asthma in our region remains too high. And the CDC estimates that 44% of all children with an asthma diagnosis are poorly controlled. We know that poor control affects children at the intersection of their health and their education, even without the severe adverse outcomes interfering with sleep, school attendance, and participation in their full range of events. And we know that these risks disproportionately impact children and families who face other barriers to reaching their full health and their potential. The causes and the solutions don't lie within any one of us individually. We know that the drivers and the solutions of these intractable disparities in asthma that we see cut across sectors. It takes our medical sector, education, housing, transportation, and environment. And the drivers and those solutions function at multiple levels, from the individual child to systems within each sector to our regional, state, and national policies. No single organization, no system, no geographic area can solve the problem of asthma disparities alone. And that is why it is critical that we are here today to establish a collaboration and strengthen our partnerships. And that is why I think each person here on site and online, their unique experiences, perspectives, and knowledge can make a contribution to finding solutions and moving us forward and closing this gap for all children. As you hear your speakers today and this wonderful expertise that is brought to us, please consider, how can we better use this data? What are new ways that we can apply it to find solutions? How can we make sure that all children are benefiting from the wonderful interventions that you will hear and learn more about? And bring those ideas and insights to our breakout sessions today and to our planning for the coming year and 2025. The good news about asthma is that we know how to solve this problem and what's needed. The challenge is making it happen for all of our children. I want to thank our steering committee and the partner organizations you've seen that have worked so hard over the last 6 months. To all of those who are here today, to our speakers and experts. And with that, I especially want to thank North Central Texas Council of Government and Susan Alvarez, who are our host here today, and who will be introducing our keynote speaker, Dr. Barry Lottman. Thank you.
Good morning, everyone. Thank you so much for joining me here at my new home at the COG. I appreciate your obvious strong interest in asthma, and it is something that we are collectively working at with the different departments at the COG. And so I am here hoping to listen and learn with y'all as well. Right now, though, I have the pleasure of introducing a friend and colleague, gentleman whom I've known for, gosh, more than I should probably say, a long time. There's a Yiddish term, Mensch, which is a wise person who is also a good person, and that fits Dr. Barry Lockman. So he is a nationally recognized leader in healthcare for the underserved. He has over 50 years experience in providing care, program development, and administration and advocacy for underserved populations. In 1968, he was the originator for the idea for the National Health Service Corps. He has held faculty appointments at the University of Rochester, University of Washington, Medical College of Wisconsin, Johns Hopkins, UT Southwestern, and University of Kentucky. He has over 30 years experience as a managed care medical director. He is nationally recognized for his leadership in the management of asthma and preterm birth prevention. I first met him for a project we were doing in Dallas called Breathe Easy Dallas, which was the first project in this area that really started looking at the nexus of health, school attendance, diabetes, and air quality. And he was an advisor on that project. And from that, he has been pulled in to help with the City of Dallas Environmental Commission as a commissioner for District, I believe, 13. And he's also co-chair of the Health Subcommittee of that commission. And he's the senior co-chair of the Texas Pediatric Society Committee on Environmental Health. His present work focuses on social determinants, the environment, and equity. And I so appreciate his joining us this morning. He is actually joining us from vacation in California with his grandchildren. And so I really appreciate his willingness to share some of his background and information on this critical topic with us here today.
Good. Can everybody hear me? Can
Yes,
you
we
hear
can
me?
hear you. Yes.
Good. I'm always uncertain when I do these about whether people can hear me or not. Are you going to be able to pass me the control and share screen so I can show my presentation, or will we need to do it? Will we need to do it with you guys showing it?
You should be able to share your screen.
Okay.
Let me know if you can't.
Okay. I will give that an effort. Let me just take care of that now. Let's see. Oh, how do I share screen here? Okay, share content. Is that it?
We can't see it yet.
Okay, I know that. I can see that. Okay. Where on the Microsoft Teams thing do I do that? Can somebody guide me through that?
Yeah, it will be on your next to where it says leave. It'll be a little arrow on the screen that points, it'll be an arrow that points up that says share.
Okay, I hit share. Aha, there it is.
Yeah.
Okay. Uh,
And then you should just be able to select your presentation.
okay.
Windows.
Share screen. Okay. Okay, you all see my screen now?
We see your screen, but we see the us.
Yeah, that was my idea. I just wanted to
Okay,
make
yeah.
sure you could.
Yeah.
So now we can PowerPoint.
Yes.
And let's see. Keeps asking me if it's okay for you guys to share. Okay, so then I'm going to hit this one, I believe, except it's not doing that.
You can
Okay.
hit the little presenter at the bottom next to where it says apply all. There's a little that one. Yeah, the one you just to a little bit lower and then to your
That
left.
one.
Yeah. There.
Aha.
Mm-hmm.
Okay. I don't want to get my punchline by going back to the beginning, so I got to go back here, and I think we're okay. All right.
Yeah.
So I'm going to talk a little bit about health disparities and the environment, and this is a part of an overall presentation where I look more broadly at uh, uh, a number of different issues. Asthma and its connection to housing and air quality, and both indoor and outdoors, only a part of that. And I would say that as we design approaches, we need to be mindful that many of the people that we are serving have more than one social determinant factor which is driving their outcomes. And therefore, it's key that we be able to coordinate approaches to offer people comprehensive solutions. For those of us like myself who grew up in public health, public health historically, I remember the days when if you had a sexually transmitted disease and TB, you couldn't get your services in one place. You had to go down the hall to the next place, and the records and nothing was shared. That will not drive better outcomes. Coordinating programs in different areas is going to be absolutely key. And I will also make the point that all healthcare is local, and therefore what happens in particular communities is of great importance and has the greatest effect on people's outcomes. That does not mean that policy and government action is not necessary. So I'm going to start with a couple of definitions here. Equity, the sense of fairness, social determinants, those conditions which affect the way people grow, live, work, and age. We'll talk a little bit more about those later. Racial prejudice and discrimination, racism is the prejudice or discrimination, and frankly, racism and the history in the Dallas-Fort Worth area that we're really struggling to overcome, as we'll see, has a part in some of the disparity, a large part in many of the disparities that we're presently seeing. A disparity is a situation in which two things are not equal, and especially when that difference is thought to be unfair. Dallas is the worst city in the country, in the United States, on neighborhood income inequality. I'm not quite sure where Fort Worth registers. South Dallas in Dallas stands out as the epicenter of inequality. Texas ranks among the worst states in most indicators of social disparities. On the other hand, the city of Dallas has developed an equity plan and a number of supporting efforts, including the environmental, a really comprehensive environmental plan. In 2020, the city of Dallas developed the CCAP, the Comprehensive Environmental Action Plan. The Dallas Environmental Commission consists of 15 voting members. I represent District 12, not District 13. I was appointed by Councilperson Kara Mendelson, who has been a wonderful supporter of the work that I've done. There are 6 non-voting contact experts and other citizen members with expertise. Each goal in CCAP has an action plan and a number of action steps, and we get to monitor those on a regular basis as members of the commission. Just a little bit of history of Dallas and equity. Texas, as all of you know, was a slave state and member of Confederacy. Texas passed its first Jim Crow laws just after the end of the Civil War, one of the first 2 or 3 states to do so. Dallas, of course, originated in what's now downtown Dallas, spreading in all directions. But as it grew south, it absorbed freedmen towns like Bonton, 10th Street, Jopley, and the bottom. Those communities were subsistence farming communities, which were absorbed by the city. The city took the land, but really until the 60s did very little to enhance those services like sewers, paved streets, electric service were not provided until after the end of segregation. And Dallas, like many other cities, used freeway construction to fence in minority communities. In the area between I-35 and I-45, we have our worst air quality, some of our worst housing conditions, and for over 40% of the population does not have daily access to a vehicle. So you're fenced in by freeways. And I heartily recommend the book, The Color of Law by Richard Rothstein, about how America was segregated. In terms of what happened in Dallas, I recommend to you reading the book, The Accommodation. I want to give a particular shout out to my friend Peter Johnson, who is highlighted in the book for fighting. Peter was really one of the people who introduced me a lot to the communities and a lot of the work that I'm involved in the southern sector of Dallas, and has been a big supporter, along with Alonzo Harris, who is a developer who has the wonderful story of having grown up in a housing project on 10th Street and now building $300,000 houses across the street from the housing project he grew up in, and who has an amazing heart for helping the community. The Dallas County, of course, as you know, does a needs survey. Parkland Hospital does it, conducts that. One of the unique things about the Dallas County Needs Survey and the work Parkland has done has been the Accountable Health Communities Project funded by HRSA, where they interviewed over 15,000 low-income individuals. So here are the big four in terms of in order in terms of needs of the population identified in social areas. Food insecurity, point out parenthetically, not as part of this talk, that the city of Dallas has a very active community gardens program. As an example, Temple Shalom, where I belong in North Dallas, we have 64 beds capable of growing 13,000 pounds of produce a year, and working partnerships with North Texas Food Bank and other distribution services. And others are doing this as well. In South Dallas, we have the Joppy Mama Garden in Joppy neighborhood, JOPPA, where, as we will see, the issues of asthma and outdoor air quality are pivotal to adverse outcomes for children and adults with asthma, and a host of other conditions related to PM 2.5, small particulate matter. Number two is affordable housing, and housing will be in the nexus of what you're going to hear from me about the origins of the disparities that we discovered when I was with the Parkland Community Health Plan. Healthcare access is an issue, again, key to outcomes in asthma and transportation. I have already highlighted the isolation of people in many parts of the city, and these will also hold for Fort Worth. Asthma in children, the effect of poor housing. The Children's Hospital Alliance for Child Health and Wellness asthma initiative identified the Dallas City Housing Code had not been updated in 20 years. The organization Dallas Area Interfaith, we're going to hear more about them later, conducted organizing effects in the Bachman Lake community north of Love Field, and identified unsafe and substandard housing as a cause of families. Therefore, we conducted at that time a walking tour of 11 housing complexes that showed horrific conditions. I would say that based on those, the Dallas City Council passed the toughest housing code in the U.S. by a 13-1 vote, with the one voting against asking for stricter changes. One white child in 10 in Dallas has asthma, and Black children, the number is 1 in 8. And those numbers, when you look at surveys, are probably an underestimate. Work done in Chicago and other cities has shown that 15 to 20% of the population in low-income inner-city areas among Black children has asthma. The national figures on Latino figures are somewhat underreported. When I was with Parkland Health Plan, we used a strict definition of asthma based on healthcare utilization as well as having the diagnosis, and we're able to demonstrate that that about 13.5% of our population had asthma, and that the differences between Black and Latino were very small. that were very small, 1 or 2 percentage points. When you looked at we used the best definition of asthma that I have seen is that of the public health directors. And we used that. What we did in order to validate that was that we looked at correlation of diagnosis with definitions for 4 different definitions of asthma, and determined that one most accurately reflected the true prevalence. Asthma is a major cause of health disparity in inner city Dallas and Fort Worth. The landmark study, of course, is the inner city asthma study, which was Dallas was one of the cities. That was done in the late 90s. And that quotes some of the numbers that I have. And when we at the Parkland Health Plan started our asthma initiatives, which you'll see some of in the next slides, the average child on Medicaid in the Dallas area had almost 1 ER visit or admission to the hospital per year. I think it was 0.9 something. We were able to, as you will see, decrease that by interventions aimed at education and better adherence by over 40%. The average cost of an asthma visit at the time this work was done was $700. I'm sure it's higher now. The average cost of a child admission, about 0.2 asthma per asthmatic child per year, again, before the initiating efforts, and before the housing code changes passed, was $6,500 per admission. And the cost of that's Medicaid cost. And the cost of ER it was estimated at $7 million alone in Dallas County. That's 2013 data. The inner city asthma study, several studies point to the role of excess moisture as a main culprit. Dr. Peyton Eggleston from Johns Hopkins, a longtime associate of mine, in his study where he was the lead, linked indoor air quality to positive skin tests, suggested that 40% of the tests were attributed to biologic growth from moisture-related allergens. And it was in this study that cockroach was first identified as the predominant allergen in inner city, almost non-existent in suburban and rural children. And mold was second. Another one, mouse and rat, were also in there. And then there was another inner city asthma paper that was authored by Dr. Rebecca Grushala, the head of allergy at UT Southwestern, and it contains Dallas specific data. Dallas was 3rd highest in cockroach sensitivity. According to the paper, cockroach sensitivity is correlated with high-rise housing. But we have no high-rise housing for children, inner city housing in Dallas. So how do we get to be 3rd? That's a great question, right? And the answer is that Dallas had the highest indoor air humidity at over 50 other states, 58% with no city above 30%. That suggests that moisture related to biologic growth is the root cause of allergen sensitivity, reinforcing the role of high moisture environments as a driver of allergic asthma in inner city Dallas and probably in other cities. When we consulted the EPA about where did this moisture come from, some of it is ambient air, but in these inner city apartments, as we will see, a lot of it is driven by poor air conditioning and by leaks behind the walls, which facilitate moisture growth. What did we do about that at the Parkland Community Health Plan? PCHP is a Medicaid HMO. At the time of this work, the health plan had 225,000 members with 92% below the age of 18. When I was there, I used to point out that I had the ideal job for a for a pediatrician with an interest in health outcomes for underserved children. The state gave us money, which 85% of, or more of what, it was more like 90% is actually spent on payments for providers and healthcare. And so we were in an ideal position to bend the curve. We began with a program to educate families of children with severe asthmatics. Then we developed a predictive model with the Parkland Center for Clinical Innovation. It predicted which child with asthma would have an ER visit or would be admitted to the hospital with 70% accuracy. We deployed the model to primary care providers for children, cutting ER visits by over 30% and hospital admissions by over 50%. We reduced the total asthma costs for the health plan over $6 million and sustained those results by the time I left the health plan for 8 years. However, I became curious because a big hole in my comprehensive asthma program was I wasn't involving the schools. And I figured I would do a pilot in an area with a high concentration of severe asthmatics. So I asked PCCI to geomap, and you can, the results. They had never done that before. And you can see the wonderful work that PCCI did around COVID and some of the work they've done linking that work with health disparities through the Accountable Communities Project. And the geomapping that we had, which was at the zip code level, we took down, thanks to PCCI, to the block and address level. And what we found is there were 8 zip codes with more than 50 members in the highest risk categories. Some of them with over 1,000. There were 3 of those 8 zip codes with over 10% of the total population of PCHP member children in the 2 highest risk categories. That percentage should have been 3%. By comparison, the Mesquite zip code had 1.7%. We had one area that was 13.3%. So something is driving that risk. Of course, the intercity asthma study suggested that excess moisture conditions, and what we determined was that the intercity asthma study was right, but they used the wrong term. They used the term high-rise housing. What we found was there was an association with multifamily housing and excess moisture, and therefore a connection to adverse asthma outcomes. And here's the asthma severity by zip code. We'll see that 75216, 13.3%, 75217, 10.5%, Oak Cliff 10.4%, East Dallas 9.1%. Waxahachie at 6.9 is interesting because how does Waxahachie get to be on that list with the high or very high members at 181? And the answer is that in Waxahachie, we had outdoor air problems, and we'll talk about outdoor air quality and its as a driving factor later on. But those were plants that produce a lot of pollution. There was work done in Fort Worth that showed that there was a correlation between emergency room visits to the Cook Children's ER and residents in zip codes with which were in the air pathway from those batch plants. So the predominant airflow pattern from Waxahachie was north and west and went right through the middle of Fort Worth, apparently driving asthma visits in Fort Worth. In cooperation with the EPA Regional Office of Code and the City of Dallas Code Enforcement, PCHP developed and implemented an environmental assessment that we would do as part of our asthma education home visits. And here's the figure. In the first 125 home visits, over 80% of the environmental assessments showed housing code violations that would affect a child's asthma. The next step that I wanted to do was because we found that landlords, that the tenants were reluctant to report because of fear of eviction. Some of the work that Dallas Area Interfaith has shown that's real. The housing project that I will show you data on later, not housing project, but the multifamily housing that I will show you data on later in this talk. After our visit there to apartments, tenants were actively threatened by staff of the complex with eviction for cooperating and showing people what the conditions were. So I developed it when I became involved in social determinants. And remember, I talked about the need to coordinate. So here are the 6 pillars of social determinants which need to be coordinated in projects. Food security, we've talked about. Safe and affordable housing, that directly affects asthma. Healthcare access, of course, affects it. Transportation, economic development, education, and finally, biosafety, and certainly our indoor and outdoor air quality are heavy in that. We've also seen that lead is in West and South Dallas is again rearing its head in adults as well as children. So that biosafety is a key factor. As an example, if you are developing a program where you are training community health workers to intervene around areas of healthcare access, employing people from the community is economic development. And so therefore you're coordinating different programs in one. And as you actively develop programs, one thing I would urge you to do is to look at the 6 pillars. And if you're developing a program in one area, find out ways that you can enhance it with some of the other determinants factors. You will have a much better effect on the overall outcome for the community. Now I'm going to talk a little about housing affordability, environmental health. What we're seeing in Dallas now, and Joy Reid on MSNBC on the Readout did an expose on this about 2 weeks ago, where she pointed out that what's happening is we have conglomerates forming mostly on the East and West Coast. They are acquiring housing complexes, allowing the aging properties to deteriorate, avoiding enforcement, raising the rents, and causing health and public safety hazards due to property neglect. We need to have solutions for communities. These properties, we'll go through that a little bit later in how that flipping of the complexes is done and why it has an effect. So one of the things we've done in Dallas is, this is a project, this is the bottom area. The bottom, if you go south on 35, your first exit south of downtown Dallas is Colorado. Make a right turn, you wind up at Methodist Hospital. Make a left turn, you wind up in the bottom. The bottom, when development started there, 70% of the land was vacant. This was when the first 4 houses were developed. There's an outstanding, the church, Golden Gate Missionary Baptist, which has been in that community for 100 years, has a foundation, the Golden Seeds Foundation. They acquired some vacant property, found that building affordable houses was challenging, and Alonzo Harris, who we talked about before, got county redevelopment money to buy down the mortgages, and there are 6 houses now that I know of that Golden Gate Missionary, that the Golden Seeds Foundation developed, which are now occupied. This project in the bottom is now in its 2nd phase. Got an editorial in the Dallas Morning News saying the bottom is blooming. And we have a community that was once a thriving community with businesses and all that basically went to hell and is now coming back. Tiny houses are a solution. This is at Bonton Farms, where they were building tiny houses. Now I'm going to shift and I'm going to talk about particulate matter and health outcomes. The size of particles is directly related to their ability to cause housing problems because very small particles, PM2.5, these factors are less than 10 microns, and they pose the greatest problems. You get deep into the lungs and may get into the bloodstream. Exposure to these particles affects lungs and heart, and numerous studies show that these vary effect on a number of conditions. Premature death for heart and lung disease, non-fatal heart attacks, irregular heartbeat, aggravated asthma to our cause today, decreased lung function, also important to us, increased respiratory symptoms, lung cancer, preterm birth, breast cancer, and within the past month, GI cancer. And people with heart and lung disease, of course, are most likely to be affected by particle pollution exposure. The EPA has just lowered its standard for communities to 9 parts per million. And Dallas is now in a non-attainment status. Before that, we were in a high but not in non-attainment before the new standard. Overall, Black Americans are 3 times as likely to die from particulate air pollution as the overall population, according to the Journal of Medicine, 2017. Particulates and diabetes. Particulate pollution is responsible for 150,000 cases of type 2 diabetes in the United States. What's this stuff about small particulates? Human, you can see that less than 2.5 is like 1/25th the diameter of a human hair. We also have PM10. PM10 is important as well because allergens can cause allergic reactions without getting down in the alveoli. And so overall particulate concentration is also of importance, particularly in exposure to some of the airborne allergens that we talked about. So we had a batch plan hearing that we conducted. We had a batch plan hearing that we conducted in that we got a TCEQ, which really needs to get its act together, unfortunately. They normally do not conduct hearings on permits, but in the Joppy area, Representative Tony Rose intervened with TCEQ and got them to have a hearing on this batch plan permit. That particular batch plan had been in operation since the mid-1950s, operating without a permit. When TCEQ did their initial inspection, they found some significant violations, but still allowed the plant to continue to operate while they were looking at the permit, which they never should have done. When they scheduled the hearing was scheduled in downtown Dallas, 7 miles away from the Joppy community, in a community where many people do not have daily access to vehicles. The city of Dallas turned around and arranged bus transportation. We had there are between 500 and 600 dwellings in Joppy. Over 100 people from the community attended the hearing, and 20 of them testified. Along with that, we had Senator Royce West, Representative Rose, and several other political figures, city council people who testified against the batch plan permit, and a group of us as experts from the Environmental Commission. So what I decided to do was to look at the asthma vulnerability index that PCCI had developed. And basically I went and looked at the zip code and the census tract that the batch plant was located in. Now, that's a little bit deceiving um, because the batch plant is in 75241. If you cross the street, uh, 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 Scott Simpson Drive to the north, guess where you are? You're in 75216. Now, let me talk a little about 75216 before I talk about the results of this vulnerability index work that I did. And this indicates the multiplicity. 75216 is in the worst it's the second worst zip code for overall health, according to the Parkland study in the Dallas area. It is the second worst zip code in the United States for Black life expectancy, second worst in the United States. High in diabetic amputations, obviously high in asthma. It is an absolute travesty of a place for health outcomes. So what about the work that I did in looking at the asthma surveillance system? 75241, where the plant is located, has the second worst asthma vulnerability. So it's the second highest asthma vulnerability of any zip code in the 86 zip codes in Dallas County. The census tract is the census tract, and you can see how South Dallas lights up in the worst by zip code asthma vulnerability. It's the particular census tract is in the worst 3% for asthma vulnerability. So obviously, to us, the outdoor air quality is driving this. What we're attempting to do right now through the health committee of the Environmental Commission is to get the distance that batch plants have to be raised to 1,500 feet. The shingle plants, by the way, are another big factor. And of course, we have Shingle Mountain. We have various plants in West Dallas and South Dallas. And of the many of these that are plants that there are, which are polluting plants in Dallas, most of them are in South Dallas and West Dallas. There are a few in East Dallas, but relatively few in North Dallas, almost none. And what we are attempting to do next is to link up the a broad variety of health outcomes data with the location of the batch plants. A graduate student from Harvard working with Dallas, working with the Environmental Commission for the summer has done some work on that and shown that asthma vulnerability is directly connected to how far you are from these polluting plants. So what we haven't done is a multiple regression analysis to pin this down to the pollution rather than other social factors. And as we did with the health plan, to look at the relative contribution of various different factors. That work needs to be done. Okay, so what are the sources of this particulate matter and outdoor air pollution in Dallas? Concrete batch plants and other industries in residential areas. The present standard in Dallas is 400 feet. We would like to raise it to 1,500 feet. Gasoline-powered lawn equipment. Gasoline-powered lawn equipment? That can't be a factor. Yes, 9% of greenhouse gases in Dallas are related to gasoline-powered lawn equipment. 9%. So it's a significant contributor. Motor vehicles, the Council of Governments is doing some nice work around showing that effect and helping to try and mitigate those effects. But a gasoline-powered leaf blower, running a gasoline-powered leaf blower for for 2 hours has the same effect on greenhouse gases as driving a Ford 150 the 600 miles from one end of California to the other. You can tell where that study was done. They emit, the noise levels are 105 decibels, which are in the level that would affect hearing for anybody within 50 feet of a lawnmower, so you don't even have to be using it. And the emission of particulates is about 50 times the EPA average. Actually, it's 50 times the old standard. So it is now like almost 100 times the prevalence, and therefore would affect anybody again within 50 feet of anybody operating gasoline-powered lawn equipment. The rental housing racket I talked about. Bachman Lake multifamily area housing complexes are being allowed to deteriorate and flipped by real estate outside management entities. Most of those are outside Dallas, most from the east and west coast. So it's not local slumlords, it's not your individuals, it's these conglomerates. They're inflating the rents. The properties are not being maintained. When code enforcement intervenes, the properties are sold to another real estate group, and we have to start over again. Joy Reid exposed this as a national issue about 2 to 3 weeks ago. Asthma and the housing scam. The moisture from leaks and poor air conditions facilitate allergens. Landlords are slow or non-responsive. The particulates in the poor maintenance areas are higher than ambient air, even though ambient air exceeds EPA standards. We had Dr. David Larry from UNT brought a team to the inspection when we looked at one of these housing complexes, and we were able to document that although the outdoor air quality was higher than the EPA standards, the levels in the apartments were several orders of magnitude higher than the ambient air in the housing complex, outside air in the housing complex. These are public health and a public safety hazard as a threat on many levels to those living in these deplorable conditions. These complexes meet the conditions for being a public nuisance, and and Dallas Area Interfaith is actively trying to work with public prosecution, which pursues the public nuisance, and also we would like to work through private sources to fix up these apartments and get them fixed. These conditions, the exposure of children in these conditions, willfully for profit, in my view, meets the definition of child endangerment, constituting a felony performed by the landlords who own these properties. Now, here are some examples from a few examples. I took pictures and videos. This is under the sink. You can see the mold. You can see the mold that has just on a vent and not vent that has just been painted over. And if you look carefully at the vent, you see the mold, but you also see that they just attempted to paint it over. And this is the standard. The other standard is leaks behind the walls, which do not get fixed. They just paint over the leaks, and therefore the mold recurs. So what can you do? Advocate for code enforcement changes with your local government and media. Identify and develop organizations fostering food security and housing solutions in your area. Promote and encourage urban agriculture, joint efforts to addressing state and local initiatives for environmental health adequacy, and advocate with TCEQ for strict enforcement of particulate standards. I thank you very much for listening to me, and I'm obviously very passionate about this. I'll tell you that when I toured Kendall Lakes on the 3rd of June, I had a degree of anger and rage about the conditions that I have not felt in years. It's really a disgrace, and the landlords and the complexes and their employees need to be held accountable for the harm that they're doing to people and to the public. Oh, one other thing by the way, saw was when we toured the complex was a swimming pool, had about 6 inches of water in it, great breeding ground for mosquitoes, and there's your West Nile epidemic coming. Thank you.
Thank you,
Uh,
Dr. Lockman. I don't know if you
do,
can hear everyone clapping, but they're clapping for you.
Oh, well, thank you. I appreciate it. And much work to be done. I look forward to working with many of you as we try to address these issues.
Yeah, if you can stay on for a little bit, and anyone has any questions, they can unmute their mic. And for our people online, you can type them in the chat if you have any questions for Dr. Lockman. If anyone here present has any questions, you can just unmute your mics.
Hi.
Before we do that, I want to tell a pride story about my granddaughter, and it contains a lesson for all of us. She witnessed a child at her school being bullied and intervened and chased off the bully. The people who are doing this to vulnerable people are bullies, and we all need to take a lesson from an 11-year-old and speak up and intervene.
Thank you, Dr. Lockman. This is Sade. This was an excellent talk. And it's clear that you're a passionate advocate for those vulnerable populations, especially those children with asthma. I will note that a child that lived in that home with the mold has asthma. I was when I was in the house and I was trying to ask extra questions to make sure she was getting appropriate care. And that was one of the concerns, that, you know, she coughed every single night and she was just on albuterol and an allergy medication. And so from that standpoint, how do you feel that we as a group of people who are passionate about asthma care and asthma management can impact those vulnerable populations from specifically from an asthma standpoint and asthma management standpoint?
Yeah, one of the things that we noticed one of the issues that we really have in intervening is that a lot of the data that drives informed decision making, some of it really asthma organizations are doing, which is, you're doing work to educate providers on appropriate management, educating people on the new updated standards for management and getting providers. And that dissemination of data is slow and it takes a lot of work and patience. But a part of it also, when you're looking at most of the care being provided by primary care providers, is that they're very busy and they lose sight of the severity of the asthma. One of the interventions that we did with Parkland that was very effective was we put an alert in the EPIC system for the people in the two high risk categories that reminded providers to prescribe the controller meds. And we increased the prescription of controller meds at the primary care visits by 50%. By that simple reminder, this is a child with severe asthma. Remember your controller. They didn't have to act on it to get past it, only to click on it. But that increased the prescribing. Now, here's the downside of that. In the Parkland clinics, the filling of the prescriptions only increased by 10%. In contrast, Dr. Sharon Davis at Los Barrios really worked very actively with her providers, and they increased the prescribing of controller meds by 40%, but the prescriptions were also done by 40%. What's the difference? In Los Barrios, you leave the clinic with your prescription. In the Parkland system, this is an issue that needs to be worked on. The fill time is so great that the parents leave, the mother puts the prescription in her purse and forgets about it, and therefore the fill doesn't get done. We need to work on the systems of care to make it easy for people to do the right thing. We showed at the health plan that home visits increase the prevalence and the knowledge of asthma. home visiting programs work. We used respiratory therapists, but there's good work indicating community health workers can do this. And that to me is one thing that we can do to improve the care. I'll tell you another story that shows how the data is siloed that needs to be brought together. I mean, clearly the environmental data and the health data outside of some of the work that we've done have not been synced up, but even the data in the health systems don't talk. So I had a very competent pediatric provider in a clinic in the mid city somewhere. And there was a child who had been to the ER 6 times in the last year for asthma. And we said to the provider, hey, how come you don't have this kid on controller meds? And she said, what asthma? And I had to send her the records that we had pulled because the ERs were not, at that point, from the hospitals this child was going to, were not sending the records to the proper primary care provider. There's an issue. We need to foster the medical home and the medical home concept to push so that the information, the proper information gets. We developed at the health plan when we would give the information to the practice in any way they wanted. If we could put it into the electronic health record, we would. But the standard was definitely old line technology. We developed a spreadsheet. The spreadsheet looked at the asthmas based on asthma risk using the PCCI index in 4 categories from high to low. So the highest category were highlighted on the sheet, on the physical paper copy in red, the lowest category in green, and the others in, I forget what the orange, I think was second in yellow. So we were able to show to people the adequacy. The other thing is what information providers need and don't necessarily have all the information. They don't necessarily know that the controller med was prescribed in the ER but hasn't been filled. They don't. So that's a barrier to care. One of the things our sheet had was how many prescriptions for controller meds have been filled in the last year, how many visits to the ER, how many visits, how many admissions. So the provider could easily see the driving factors, because when I'm the provider and I'm seeing that patient who is not in good control, obviously not in good control, unless I know about whether the parent understands and is giving the controller med and following the guidelines, I don't know whether I just need to be more aggressive about managing in my office or whether I need to be a referral. And we really saw a large amount of under referral to pediatric pulmonary and allergy providers. And we need to change the system so that there is better coordination of data, but also better coordination between providers across the silos. So I think that gives us a lot of work to do.
Yes, yes. Thank you, Dr. Lockman. Thank you for being here today and taking time out of your vacation. And thank your granddaughter for stepping up and giving us all inspiration for today. But thank you again. Everyone, if we can clap loud enough for him to hear. Thank you so much. Please have a great rest of your day.
I will. Thank you. And I hope everybody found it useful.
Okay, everyone. We will now proceed with our 15-minute stretch and coffee break. So, of course, you can help yourselves to coffee that's still in water and drinks in the back. And then we do have our resources in the back as well that we can share. But I also want to share our word cloud question. So if you could please scan the QR code. And we do have a question for everyone today. So the first question, which I hope was inspired by what we just saw and heard, what three drivers of poor asthma outcomes do you think are most important? So there you'll see some examples. You can definitely use some of these examples as your choices. We do have indoor air quality and triggers in the home, outdoor air quality and triggers, lack of access to medical services, inability to afford medication, cultural barriers, language barriers. So we'll have the word cloud up so you can kind of see what the choices are from the people in attendance online and in person. And then as you answer, you can go ahead and head back and enjoy some of our resources, food, and drinks back there.
Yeah. See. keeps doing it.
everyone. If we can have you come back to your seats, we're going to proceed with our presentations. Okay, everyone, we'll go ahead and get started with our next presentation. Yeah. So I want to first thank you all for answering our first question. If you're able to see the word cloud up there, we had a lot of great responses. Now I want to introduce you to Kelly Wilmore, who is Public Health Specialist for Dallas County Health and Human Services. She will be introducing our next speaker.
Thank you, Leslie. Good morning, everyone. I am here to introduce Dr. Cesar Termelo. He received his undergraduate degree from the University of Notre Dame. He completed medical school at UT Southwestern in Dallas and then finished his residency at Children's Health in Dallas. He's been practicing at Parkland Community-Oriented Primary Care as a general pediatrician for 23 years. He's married and his 3 children were all born at Parkland Hospital. And he's here today to talk about the Dallas County Community Health Needs Assessment and asthma collaboration. So let us welcome him.
Thank you, everyone. I'm very excited to be here, and I appreciate everyone's interest and the need for collaboration on this issue. So my name is Cesar Trum. I'll try to get close to the mic so you can hear me pretty well. So I am a general pediatrician. I work at the Hatcher Station Health Center in Fair Park. Associate Medical Director of COPC at Parkland Health. We have 15 COPCs or primary care clinics across Dallas County. Next slide, please. So as we know, I'm not going to go fully into this, but as we know, asthma is a significant issue in our country. Over 4.6 million children with asthma nationally. Over 7% of the pediatric population have asthma, and there's a significant amount of mortality that occurs. There's a significant amount of patients in Texas, 1.8 million, that have asthma, 295 episodes of mortality in 2021. DISD, over 9% of students have asthma. Next slide, please. So we know that asthma is a marker of disparity in our country. Over 3.8 million patients in the U.S. live less than the poverty threshold. We know that asthma-related ER visits are nearly 5 times as high for Black patients compared to white patients, and we know that there's 2 times the mortality of Black children compared to white non-Hispanic children. Next slide, please. So as tasked by all nonprofit hospitals with the Affordable Care Act, Parkland is obligated to do a community health needs assessment. So as Dr. Lackman discussed in his nice presentation, his beautiful presentation, we interviewed thousands and thousands of patients to try to understand the needs of the patient population that Parkland serves. So we started in 2016, and we've had 2 iterations since then. Many initiatives were created in response to our community health needs assessment. So pediatric asthma was just one of them, but you can see that there were a lot of other initiatives that we started, such as diabetes, breast health, postpartum mortality as well, hypertension, and sexually transmitted diseases. Next slide, please. So, and as pretty much correspondence to what Dr. Lackman's slide had shown, and that our certain zip codes were most high at risk for pediatric asthma, most notably in South Dallas, and also especially Southeast Dallas and also West Dallas. So the data that we found pretty much corresponds with what Dr. Lackman had exhibited. So I don't know if he got it from the same data that we did, but so we know that when I take care of a patient, I might do the best I can to put them on the appropriate control of medication in addition to the rescue medication. But one thing that I know is that when they leave my clinic, not necessarily whatever I do is going to affect their eventual outcome with asthma, that we need to be able to use multiple partners within the community to be able to have an appropriate effect on their pediatric asthma outcome. So next slide, please. So knowing that with the CHNA, Parkland engaged in collaboration with the community. So we began collaboration with PCCI, Dallas County Health Department, and Positive Breathing. Next slide, please. So many of you know Shamara Norris, who is here. I'm very happy that she is here. There she is over there. So she outfits a van to do mobile spirometry in communities. So she's able to do spirometry. She goes to where people live and play. She'll park outside of school. She'll go to community events. She is able to do spirometry so it's such that those patients, or I keep saying patients, but that portion of the population that might have asthma, but they aren't really aware, her spirometry will be able to alert them to the need that perhaps they do have asthma, and also for the students that do, or patients that do have asthma, they might have a better idea that their asthma might not be in good control. So they're a very important part of our collaboration to be able to get to places that, as Parkland, we cannot get to. Next slide, please. So in addition to that, Parkland does have its own community outreach events. Through our CHNA, we have 4 centers in which we are in a location weekly. And not only do we do screenings on pediatric asthma, but all the other initiatives that you've seen on the previous slide. So in addition to regular community outreach, we also go to pop-up events. So the slide on the left is actually an event that took place at Juanita Craft Center near my clinic. It's organized by John Wiley Price, a health fair that takes place every year. So we do try to go to other community events as well, and we try to get our community health workers to a lot of these events that go on in the community. Next slide, please. Okay, so that's community outreach and our collaboration with Shamara and the asthma positive breathing. Next is PCCI. One thing that's important for me as a physician is that I can see a patient only for about 20 to 30 minutes at one time point over, and I might not see them again for a few months. So one thing that's important is to be able to leverage technology to be able to take care of their asthma in the large patient population that we have in Parkland. So our partnership with PCCI has been extremely important. I want to acknowledge Dr. Pengetsny, who is here and will be giving the next talk. I also want to acknowledge that I basically stole her slide as well. So I basically copied and pasted her slide. So one thing that PCCI was able to do was to take data from our EHR, but also other data sets, such as the DFW Hospital Council, to know which of my patients are not only coming to Parkland, but also who's filling their prescriptions, also whether they're going to other ERs, to be able to develop a risk prediction model to see which patients are most at risk for showing up in the ER. So from that, we're able to tier which patients are most highly at risk of showing up to the ER. And as Dr. Lackman had mentioned, that was part of a clinical workflow integration where I would see a patient and a best practice alert would show up on my screen. And so what would happen is that I would see a patient for, say, headache or ADHD or something where I'm completely not thinking about asthma, but yet the BPA would show up on the screen, and then it would alert me to the fact that it's something that I need to address. So either I address it at that visit, or I try to schedule a follow-up with our asthma team to be able to make a follow-up and assessment of their asthma. So it was sophisticatedly, I don't know if that's a good word, but it was integrated well into our workflow so that it wouldn't be too much of a burden on primary care physicians to be able to address their asthma. So from that risk prediction model, we also developed monthly risk reports. So those reports were also shared with Dallas County Health Department, and I'll talk a little bit about that later. The other initiative that was started through PCI was a text messaging system. And so next slide, please. If you want, you could scan the QR code right there. We did create a Parkland video on how the text messaging system works. So basically, patients receive a regular text messages on with two questions: how is their asthma doing, and also how many doses of the control medication that they missed. So what happens is that is compiled into a report, and that report is then given to our asthma program manager, Jason Allen. So Jason Allen then tries to reach out to those patients who might not have very good asthma, and their asthma might not be under control. So then he can call them and also perform the asthma control test, and he'll call them to see if perhaps they need to be seen in the clinic. Because one thing we know is that for the large population that Parkland serves, it's not going to be easy if a patient is having some problems to get into the clinic. So what he's been able to do is we've been able to remotely monitor our patient population and try to bring those patients that are most at risk for asthma attack in. So it's kind of a nice story. The lady on the left, her children go to Parkland, and so we did a lot of education about her asthma. Her child is now in medical school, and her two children are doing well in high school as well. Next slide, please. So I mentioned the monthly risk reports that PCCI generates, and so that risk report is then given to Dallas County Health Department. So they have an asthma control program. So they take those patients at highest risk for asthma, and they do virtual visits with those patients. They will administer the asthma control tests, which many of you know basically is a series of questions, which gives you a snapshot onto the asthma control to give an idea if their asthma is doing well or not. They also perform education on the asthma action plan, and as a pediatrician who only has about 20 to 30 minutes, no, not even 20 minutes. I have 15 minutes per patient. I do not have sufficient amount of time to be able to talk about the asthma action plan. So being able to understand the nuances of when to give control of medication versus rescue medication are very difficult to do. So that's one thing that the asthma control program can actually do, is to spend time to be able to educate on the asthma action plan. And so those patients that are seem to be doing poorly in the asthma control test can also be referred to Parkland, and we can also try to get them in. And then follow-up takes place through the virtual visit program at 6 months and 12 months. And it has been shown that those who engage into the program, they do a little bit better on their asthma control test and their compliance with the asthma action plan. Next slide, please. So historical performance, and once again, I need to say that I stole this slide from PCCI. So historical performance has shown that it has made an impact in our patient population. For those patients in the Parkland Community Health Plan, there's been 42% less asthma ER visits. For those patients in the CHNA zip codes, there's been 36% less ER visits, and additionally 59% less systemic steroids and over 60% less asthma hospitalizations since we've started this program. So it's been shown that there's been good historical performance in the model that we've engaged upon, and the collaboration that we all have together. Next slide, please. And so one other thing that's happened is that Kaiser Permanente had a grant, and this was more about artificial intelligence and AI, and trying to find programs which you engage on AI in healthcare settings to improve health outcomes. So over 125 healthcare entities applied, and we were one of 5 that were chosen to receive a $750,000 grant. So what we are trying to do is try to use the asthma model program and collaboration that we have started. Next slide, please. To expand it to other locations, to 2 other FQHCs at Foremost and Los Barrios. So Sharon Davis, that Barry Lackman had talked about, she is at Los Barrios. So we do have community partners that will be trying to expand this current program that we initially have right now. Next slide, please. Future directions is asthma 411, and all of you here know that asthma 411 and unassigned albuterol in schools is currently in play at Fort Worth, but we are very hopeful in collaboration with Children's and the ISD, with Children's being represented by Dr. Sade Afalabi, and then a lot of our residents over here to the right are here as well. So through their initiative and their desire there. We're trying to engage the ISD, and so I'm hopeful for that as well. Next slide, please. I intentionally left out the Texas PASS program. Dr. Pengetzi will speak about that next. But lessons learned, number one, is importance of reaching out into the community because, like, as I said, one thing I realized is that there's a lot of asthma out there that is not coming into my clinic. So we have to find a way to be able to remotely monitor our patients, but also reach out into the pockets through outreach of patients with asthma that are not coming into our clinic. Number two is importance of collaboration. I realize that as a pediatrician, the things that I do will not fully affect a patient's asthma, and that we need to be able to collaborate with other community-based organizations to leverage their strengths to have an effect. Number three is the importance of understanding misconceptions of asthma. We still have a lot of education that needs to be done, especially one thing that stands out with our the virtual visits that Dallas County Health Department does is a lot of people feel that their asthma isn't really asthma. They feel it's just allergies, or they feel it's just, they just have a lot of upper respiratory infections. So we still have a lot to do in terms of education about asthma. And then the last point is importance of leveraging technology, importance of technology to be able to remotely monitor our patient population, but at the same time, reach out to patients to give them the care when they need it, and also to provide remote education because those things cannot always occur in the clinic. So that is the end of my presentation. I look forward to questions at the panel discussion later on. Thank you very much.
Thank you, Dr. Termelo. Next, I am here to welcome Dr. Yolande Pengetzi. She's a pediatrician, physician scientist, and VP of Clinical Leadership at Parkland Center for Clinical Innovation, or PCCI, with over 25 years of experience in clinical and healthcare leadership, leveraging advanced analytics, technological innovation, and care transformation to promote community health equity. She's here to talk a little bit about the pediatric asthma surveillance system. So let's welcome her.
Thank you. Thank you, Kelly. Can you guys hear me? Okay, that's awesome. Well, thank you all for having me, and it's a pleasure to see that like-minded people are coming together to try to tackle this issue. And you would think pediatric asthma is a simple issue, but there are a lot of intricacies to it, as you've seen from the keynote speaker, Dr. Lackman, and from Dr. Teomulo, and from your experience in the community. So next step. So we're going to talk about a pediatric asthma surveillance system. But as a background, I'm coming back to the community health needs assessment implementation plan that Dr. Teomulo just discussed. And that's where this idea incepted from. Because as we were implementing the asthma program and talking across the health system, the public health system, community-based organization, and data system, we realized that just working together from the same perspective, data-wise, having an understanding, a common understanding of what the issues were, what we were to do, and then splitting that work to enhance each other's strength, leverage each other's strength, actually was probably the most effective way of approaching this problem. On the other hand, you can certainly know from what's happening in the community that many things happen, but in silos. Everybody does something. And sometimes we're concerned because the same patients receive multiple interventions. They never really get better because it's now up to the patient to put that together. But maybe maybe a better approach we should have would be to create some sort of a common set of understanding and create a platform that will allow us to, and I'm a data person, to collaborate in a data-driven manner. So we know who is the most appropriate person to do what for whom, and we can design those programs accordingly. So that's basically that public health core function of monitoring health, but then diagnosing, investigating, and then designing and implementing interventions. Next slide, please. So as you know, better than anyone else, pediatric asthma affects quite a few children in the US. It's a major risk factor for pediatric morbidity and mortality in Texas and in Dallas. But then there are health disparities in both diagnosis and outcomes. 12% of Black children have asthma versus 6% of white. Excuse me. And from federal poverty level standpoint, 11% of children living below 100% of federal poverty level are diagnosed with asthma, whereas only 7% above 450%. These differences are not genetic, right? Your level of income doesn't determine your genetic. These differences are socioeconomic for the most part. So, and then you can see the data on controlled asthma. Many children with asthma have uncontrolled asthma will end up in the emergency room or with a severe asthma attack once a year. And over 200 children die from asthma in the US in a given year, and 8-fold more for Black children than for white children. Again, that's not genetically determined, it is socioeconomic. So next slide, please. So the key drivers of asthma, I never give a talk about asthma without giving people like clean background, right? So the key drivers of asthma here in Dallas County, we saw, like you've seen on all the slides, the southern region is affected, and we identified 6 zip codes, targeted them for the CHNA implementation plan. That's an ongoing process. Dr. Termulo explained the risk prediction model that was used by everybody to design and implement outreach and interventions, the text messaging program. But what we realized was that there was a lack of community consensus, right, on where the issues are, what the issues are, who should do what, and the lack of integration across data systems. So that's where we stepped in and decided all together, Dallas County Health Human Services, Waldo and his team, Parkland, Dr. Termulo, Teresita Oaks, that you guys probably know of, and her team, and then PCCI, and to start to come up with the pediatric asthma surveillance system as a common source of truth when it comes to asthma in the region. So next slide. So it is a community-facing tool that is hosted on Dallas County Health and Human Services website. That is the QR code, if you were to scan that, you would land right there on the page. You just scroll down and you will find it. And what we did was we built an index. I don't know what's happening. Excuse me. All right, thank you. So we built an index, and the index was to summarize the risk across clinical and social risk, because you do have the clinical risk. If someone has allergies, they don't take their medications, that's an issue. But if, and you'll see it's fascinating, if a parent has to choose between feeding the family and taking the child to the doctor's office, they're going to choose to feed the family. So not addressing food insecurity can affect asthma. It seems like, there would be no relationship, but socially there is a clear relationship. So it's always important to bring those together so that the clinician in their office may have a fairly good understanding of what the medication adherence patterns might be for their patients. They may just not know that this patient lives in a neighborhood with a lot of smokers. The caregiver themselves may not smoke, but the patient is still exposed to secondhand smoking. That would certainly help the clinician have a different approach to addressing asthma for these patients. On the other hand, the public health system knows about, smoking issues. They do know about possibly the conditions in the community. What they don't know is if this patient is attending their appointment, if they have a problem with health insurance. That cross-communication can actually help us synergistically improve these patients' outcome. That's what we were aiming for when we built the Pediatric Asthma Risk Index that is incorporated into the pediatric asthma, into PASS, the Pediatric Asthma Surveillance System. Next, please. So this is really a lot of details about how we designed and approached it. I'm not sure if you would be all that interested in it, but it was mainly trying to predict pediatric asthma risk at the community level within the next 90 days. 90 days is an important time frame because it's 3 months. If I predicted and told you your child's going to have asthma tomorrow, there's very little you can do to prevent it. But if I did predict and tell you they'll have asthma in the next year, you don't know if it's going to be 1 month from today or 12 months from today, so you don't know when to intervene. 3 months is a fairly reasonable time frame during which you can curb the the risk for asthma, yet not too far out that you would have to work on a long period of time. And we pull data from different sources, from the census, data from CDC, but also from Parkland EHR, the Dallas County, the Dallas-Fort Worth Hospital Council Foundation, from open weather data, because particulate matters that Dr. Lackman was talking about are things that open weather can give it to us at fairly a fairly discrete level, and we applied some statistical techniques to integrate all those data into a risk index. Next slide. And then, of course, it's important to deploy this. So we had to engage and train key stakeholders. And I'm sure some folks in this room came to the training. And then the next important thing is to monitor and make sure people are actually using this tool, right? Because it's one thing to have it out there. It's something else for people to actually use it, engage with it, and get some feedback from them, understand if there's anything that we need to do to make it more useful to the community. It's truly a community tool. Next, please. So this is the details of how we went about it. We started with 117 variables from different data sources, and then we analyzed them to make sure that, you know, we only isolated those variables that had a unique contribution, not those redundant variables. We decreased the number of redundancies, got down to 67, and then put them into what we call a multivariable analysis. And that multivariable analysis selected 10 variables that were together better predictors of pediatric asthma in the area. But at the same time, next slide, so once we had this built, we were able to re-stratify specific region down to the census tract. We could tell you if the area is, the census tract is very high, high, medium, low, or very low risk. So we had that split. Next, please. So, but in addition to those 10 variables that you see to the right, and my eyesight is terrible, but I can give you from so the variables that contribute to the model range from, you know, how many controllers do patients take, which is, are they taking their medications as appropriate, to do they have do they take reliever medications? Are they having active symptoms that are causing them to be requiring more of their reliever medications? To have they had any emergency room visit in the past 90 days? Because people who had an emergency room within the past 90 days are more likely to have it again if nothing is done in between, right? But then what is it that we have to do in between? Some of it is in the 7 factors right there to your right, because together with Dr. Termulo, Waldo's team, and other providers, we came together and we decided, okay, it's important that even if a variable didn't make it into the model, if it's one that is important for us to understand what is driving the risk, then let's still put it out there in the report so people can have that next layer of understanding where the risk lies. And those are extremely actionable variables, things like smoking cessation, depression, caregiver depression, things like insurance, access to healthcare, to health insurance, transportation. Those are key variables that are important for us to further understand, to keep to peeling those onion layers and understand deep under what are the drivers of risk. So on the pass, you have those 10 variables that always are highlighted when you're looking at the pediatric asthma vulnerability index. But then there is a tab where you can go to further dig deeper to understand what else is potentially driving risk in these communities. So next slide, please. So this is what the PASS dashboard looks like. So you have it at the zip code level. So if you click on the tab to the left, you have it at the zip code level. But if you do click on the tab to the right, you have it at the census tract level. But we still leave those zip code markings because many of us have worked with zip codes so long that it's always important for us to still have that reference back to the zip code, right? So we have it there. Next slide, please. And then once you click on a specific region or area, you will have a listing of the risk drivers. You'll see the area, of course, you have at the bottom, you have some sort of a legend that tells you what the color coding represents. So you would know if your area is very high, medium, or low risk. And then you'll have a description of the population right there at the bottom. Those bar charts tell you the age, the gender, the race and ethnicity, the education attainment in that area. But then to the right, the listing to your right, to the right of the map, is the listing of the risk factors in that specific area ranked by order of importance. So every time you click on a different area, it changes depending on which factors are important in that area. That is extremely helpful for us to understand what exactly is going on in those communities. And then, like I said, to the right there is just describing that at the bottom you have those social demographic insights that help you understand what is the composition of the population in these areas. Next, please. So one key insight that we got from PASS was that we have a lot of approaches, a lot of our strategies are zip code based, and that's reasonable. However, when you dig deeper into the community, you can realize that within the same zip code, you should have different strategies from different communities. These are two contiguous zip codes, I believe, in Northeast Dallas. So those are two contiguous zip codes, but they have two very different risk profiles, right? One is low risk, the other is high risk. One has low ED utilization, the other has high ED utilization. One is made of non-Hispanic white, the other is made of black males, and then and so on. So all those information will inform the approach that you can have to intervene in these communities, regardless of what you're trying to accomplish there. Next, please. So I'm going to share with you a few preliminary insights that we gained from PASS, but the idea here is for you to be able to use it and gain additional insights. But what we saw was that to the left is your general vulnerability in the county, and those children vulnerable to asthma to the right use the emergency room more than those non-vulnerable. That makes sense. That was the purpose of building this tool. Next slide. They also are exposed to adult smoking. You can see a clear overlap between many of those areas and caregiver or adult smoking. Next, please. They have a higher prevalence of adult depression in their communities. And I know everybody will ask me, what does adult depression have to do with asthma? If a person can care for themselves, they probably won't be able to care for their own children. Next, please. They live in areas with high prevalence of food insecurity. Next. And they have a high housing and transportation needs in general. Next. And then they use controller medications ineffectively, because it turns out that when we checked about how many of who got the controller medication prescriptions the most, those children at high risk actually got controller medication prescriptions the most. But they're still going to the emergency room, means there is some issue here. It could be that they are not filling those prescriptions. It could be that they're filling them, they're not taking them appropriately, because some people think asthma is an as-needed disease. When I have symptoms, I take controller. When I don't, it is totally the opposite. The goal of controllers is to prevent asthma, means you need to take it so that you don't have system and continue taking symptoms, and you continue taking it so that you still don't have symptoms, right? You don't stop it when you're feeling better. It's not pneumonia. It's not an acute disease. You don't take medication and then asthma is done. You take medication, asthma controls, mean you need to continue taking it. That's an education we need to keep having. Or is it that some of them live in areas where trigger exposure is so permanent that throwing all the controller medications at them is truly not going to be helpful, right? Dr. Lagman showed you, if a child lives in a house with mold, you can put them on controller medication. It's going to help for some time, but they are going to be overwhelmed at some point. That inflammation can be controlled if it continues to be permanent. So we need to address those underlying issues. And just this revelation was totally, it took us aback, because what we were expecting to see was that they were not taking their controllers, but no, it seems like they actually have those prescriptions. But if they keep ending up in the emergency room, that means we need to do more than just throwing prescriptions at them. We need to go beyond that. Next, please. So by the numbers, this is what for the 1 year anniversary of PASS launch. PASS was launched in December 31st, 2022. 31st because we had to, there was a deadline for us to have it launched by the end of the year. But it was really rolled out January 2023. So by January 2024, we had educated 15 organizations through 6 training sessions. We have 50 people trained, and we had others reach out for further training. And looking at the website access, we had close to 3,500 views. That means people actually reached out, started using the website, multiple social media mentions. But I think beyond that, what was really important to us was the conversations we had with community stakeholders. And what we saw was that people have like different avenues for using the pediatric asthma surveillance system. Public health interventions, maybe the smoking cessation program could be, you could leverage this. Environmental advocacy, we had some folks coming from the city to learn more about, the overlaying, like Dr. Lackman was explaining, of cement plants and asthma risk. Maybe the advocacy is a little more potent when you have those data overlaid than just when you're talking about one or the other. Residents, I think we have some of our residents here, and they've been leveraging PASS to do some interventions. That's extremely encouraging. We had school folks come for training and start thinking about ways of implementing it. We even had someone from a corporate social responsibility that came by and got trained and asked us to train their team because they felt like, this gives them enough insights to be able to initiate interventions in a data-driven manner, take it to their leaderships and have that supported by these interventions. But we want to go further. We want to make sure that first, as many community stakeholders as possible use this platform. And second, we do have a feedback form on the platform that you guys can use if you use it, or if you educate folks to use it, to provide us with feedback so we know if you're using it, what issues you had with it, or if it was successful, let us know. We just need to be able to gauge how much impact we have with this. And moving forward, we will continue monitoring how it's used and whether it's helping create more data-driven coalition around pediatric asthma. So next slide is hopefully the last. So, and Dr. Termulo showed us the CHNA, and we saw that there's more to it than just pediatric asthma. There's cardiovascular diseases, maternal health, behavioral health. So our goal is to try to replicate PASS for these other conditions. We're actively working on a diabetes and hypertension surveillance system. So, but maternal health, mental and behavioral health are just right there on the deck next. So we appreciate your attention. And I know it was a lot of data, a lot of things thrown at you, but we're here to answer questions if you have any. Thank you.
Thank you, Dr. Pingetzi, for your data and all the data that your team has collected. I feel like all of your data, all the information that you both have shared regarding your collection methods and implementation have inspired a lot of people today. So keeping the importance of data in mind, I want to introduce Dr. Courtney Bernard. She is Director of Child Wellness for Cook Children's Center for Community Health. She will be introducing our next presenter.
Thank you. Yes. We'll ask Savannah to come on up. This is Savannah Panagopoulos. She is a community health analyst at Cook Children's at our Center for Community Health and our Child Health Evaluation team. So part of her role is to help design and collect data and analyze our data and formulate it into recommendations for action as part of Cook Children's Community Health Needs Assessment. Savannah has quite a history in varied health topics, especially around health equity. She's done work in Central America and has lots of interest in the social determinants of health. So she's been a great addition to our team several years ago. She's passionate about improving the well-being and equitable access to healthcare for all members of our community, especially those most underserved and underrepresented. So Savannah, I'll pass it to you.
Thank you. Hello, everyone. Thank you so much. It's a privilege to be able to be here today and present to all of you and hear more about the work that you're doing around asthma in our communities. So I'd like to talk to you today about the Cook Children's Community Health Needs Assessment and how that data is kind of utilized, some of those findings, where it comes from, and how that ultimately impacts our strategies to address asthma in the 8-county service area that Cook Children serves. Next slide. All right, so as I just mentioned, we'll talk a little bit more about that CHNA in depth. I'll identify some key results from one of our methodologies. And then I'm going to also share with you our now public data dashboard where all of our survey results live and how you can utilize that data. And just a reminder too that in our North Texas area that we serve, we are estimated to be serving around 1.2 million children that live throughout the community, or that's the total population of children that we will be estimating our data around. So next slide. So some of the methodologies for how we collect our data, I'm actually going to talk a little bit more about that face-to-face interviews with those underserved families. So this is our unique opportunity to partner with another local organization to get these data points I'm about to go over from families that would traditionally be missed from typical survey collection. Such as families that are living in homeless shelters. So we're very fortunate to have a community partner that was able to also collect data from these families that are some of our most under-resourced in our community. And then we also collected some qualitative data from our families in one-on-one interviews that are enrolled in our programs such as asthma. And I'd like to give a big shout out to the community health worker ladies for your amazing work and the rapport that you build with these families so that they feel comfortable to share with us more about the barriers that impact their care, especially around asthma. And so from those interviews, we were able to understand more of the story, the overall story of what our data is also collecting. For example, this is where we hear from families that note food insecurity, affordable housing, as you've heard all day, and even wait times and finding specialists impact their child's asthma care. We also get to talk to our community leaders and survey them, interview them one-on-one, and like to hear from their professional perspective about what's also happening in the community. And then, of course, we have our secondary research. But today, what we're going to focus on is data from that parent caregiver survey. And what's neat about our survey is it is a descriptive parent perception survey that's sampled throughout the 8 counties. And we ask questions that are related to child's health, asthma being one of them, but also around different children's health topics. And so our CHNA began in 2009, and at that time there were 7 health topics that were identified as priorities from parents and community leaders across our counties. And so our questions also focus around injury prevention, mental health, healthy lifestyles, oral health, and parent and family support. So more about that CHNA is from that report, we're then able to create implementation strategies that are both data-driven, but also involve community voice around the strategies that will be best to serve our families that are services rolled out through our programming. Next slide, please. A little bit more about that survey data. So we survey families with children 0 to 17 years of age. Again, it is a parent perception-based survey, and it goes out across all 8 of the counties. So you can go to next slide, please. So some of our key results, our number one question we ask is, has your child ever been diagnosed or told that they have asthma? So across our 8-county region, we had 89% in around 1.1 million that indicated their child does not have asthma. But we had around 8%, which is 99,000, estimated 99,000, indicate that they have been told their child has asthma and they currently have symptoms. And then we had around 3% or 37,000 that indicated they had been told at one point their child has asthma, but they do not currently have asthma symptoms. Next slide, please. So within our survey from our asthma section, we found that 42% of children with asthma had an episode of asthma or asthma attacks within the last 12 months. And so that's estimated to be around 58,000 children. And this is across that 8-county service region. 14% of children that indicated had asthma had been to an emergency room in the past year because of their asthma symptoms. This is almost 20,000 children. 87% of children with asthma did receive all of the medications that were prescribed to them for their asthma treatment, but that still leaves around 12% that did not. And 37% of children with asthma do not have an individualized asthma action plan. That's close or estimated to be around 50,000 children without that direct managed action plan. Next slide, please. Okay, so now our data dashboard. If you scan that QR code, you can find these asthma findings as well as the other health topic questions from our parent caregiver survey. We're super excited to be able to have this data on an annual basis to share with our community partners. Our Asthma 411 and Healthy Homes programming out of the Center for Community Health works deeply collaborative with around 600 different, or our center works with around 600 different partners within our communities. So we're also excited to be able to share data with our community partners, our families as well. So our CHNA is conducted every 3 years, but we are collecting this data on an annual basis. So when you go to that data dashboard, currently you can filter that data down from 2021, 2022, and 2023. You can look at the overall data, which is what I highlighted today, but you can also filter that data down a little bit further, such as by the county. If it's a county, your county specifically you'd like to look at, and we have that 8 county service region. You might also want to see how those asthma questions differ for child, race, and ethnicity. You can also filter it down by the age group of the child, as well as the household income. And that special populations filter is that those surveys from families that aren't traditionally able to take the survey because they're in unique situations such as homelessness. So you can even look at the survey results from there. And again, this data dashboard covers our asthma data as well as other children's health indicators like insurance coverage and issues with the gaps in coverage. We also have the mental health tab, our safety tab, and family and caregiver support. And the reason I highlight these other tabs is they all contain factors that ultimately impact a child's access to asthma care or might be influential on why they're not receiving care that they need. So, next slide, please.
Thank you, Savannah. And thanks
Thank
for
you.
that walkthrough of the data dashboard. I'd like to invite all of our data speakers to join Savannah up there so we can have a panel discussion. Dr. Bengetse and where did you go? There you are. Okay, I couldn't remember where you were sitting. Dr. Termulo, thank you. And while they're getting situated, I'd invite all of you all to begin thinking of any questions you may have. We'll be able to share and have a conversation here. And for those of you online to write any questions you may have in the chat, questions or comments, so that we can incorporate those as well. But as I guess to kind of kick us off, Dr. Pengetse, you shared some use cases for your data. You've got your highly accessible data dashboard to play around with to show all the indicators for people to play in there. And you all have a data dissemination plan to try to get as many people aware of what data is out there to create that common foundation. And I'm curious for Savannah and Dr. Termulo if you have similar use cases or hopes for or opportunities for others to access your data and what you hope they might do with it in your communities.
The question is whether we have our own data and whether it would be able to be accessible.
Yes, if others can, how others can access your data, and then what you hope others could do with it, given, right, the potential solutions we're trying to outline here.
Well, we do have our CHNA report, which is online. We do have our CHNA dashboards, which are more in Parkland facing. There can be discussion in terms of being able to have that data more outward facing. But I'll tell you, we haven't really discussed that at this point. But I could see how as we continue to collaborate, that there will be a need for something like that.
Mm-hmm. Thank you. Savannah?
Yeah, so as mentioned, we'll have the data dashboard. The full 2024 report will come out around late spring, early summer 2025. But also our goal with that data we've collected is really to, while we're in the community, share that with our partners and roll that out through our different program coalition meetings and action team meetings, and just make that data accessible, because it is more of a community voice-based data collection. It is the parent perception, and I think it really gives a more insight into maybe what the community's facing, and really those social determinants that you've been hearing about today.
It really seems like those community voices through the interviews help us better understand the nuances that might be faced by families. So something that a static data metric, might give us the first glimpse, but to go deeper. And Savannah, you mentioned that you all have used those caregiver interviews to help identify food security and others. Could you share a little more about what may be coming out of those interviews that help you interpret the other data you have?
Yes, so the goal with the qualitative data collection is to see where, if it does fit in conjunction with those data points, to really help tell the narrative or the story further. I love that we have a parent caregiver survey, but I am really more interested in going out and hearing directly from those families. I want to know, what are the barriers to care? What are things that us and our community partners can help improve so that you have equitable access to care? I want to hear directly from families. So I think having both that quantitative and qualitative collection to really help tell that story, and then help influence resources you can provide, the types of strategies that you will use to address those issues in the community.
As any good mixed methods researcher would do, yes. Dr. Termelo, what about you? You all in your community health needs assessment interviewed thousands of patients, right? Mm-hmm.
So we actively have many community health workers that engage the community. We do try to hire community health workers that actually live in those communities as well, because part of our initiative, as per our leadership, is to be able to realize that we are just an anchor to what is out in the community. So the model that we have is we are anchored with other community-based organizations to be able to address the needs of the community. So we do have many community health workers that are out there at the community hubs that are assessing needs in the community. So the hypertension, the diabetes, the postpartum mortality, and STDs and things such as that. I can say though that it's not the data that we've collected. It's probably with the heads of Teresita Oaks. It's probably in her wheelhouse to be able to share that data. And to make it public. But we have metrics on our dashboard, but not those specific issues. But that was basically what, the specific interviews with families is what led to our creation of the different initiatives of the CHNA.
And maybe to supplement Dr. Tremulo's response, CHNA-wise, Teresita Oaks owns the data, but he actually discussed in his presentation the fact that we're planning on disseminating to other smaller less resourceful health systems, some of the data approaches that we've implemented. So that's one of the things that we got from the Kaiser Permanente grant. That is, it is difficult for FQHCs to be able to have the access to resources that Parkland does. Quite frankly, they're all safety net systems that they take care of slightly different types of patients with fairly different systems. So what we did was to get that grant from Kaiser Permanente. So the risk prediction model and the implementation plan that we had at Parkland that was successful, we will test and see if we can generalize it to those two FQHCs. And if it's generalizable, then it's just a good, it's basically just a good blueprint for how we go from a large health system R&D to making sure that those information and sophisticated tools are available to everyone else.
And I think, this meetings like this are really important so that we can raise awareness in terms of collaboration with other health systems. Because so far, Parkland, we've been trying to just, go on our own with our patient population. But I do realize that it's now something that we'll be able to share our the data that we've gathered with other entities in the community.
Incredible. Yes, I'll open it to our group here. Dr. Alsop.
So thank you all so much for this incredible work that you've done. And I know it's years in development, and I'm so grateful. We know that one of our primary objectives from this summit today is to identify sustainable collaborations. So we both have the collaborative learning from different areas of our region, but that we can also identify some of the issues that are regional in nature and really need our collaboration to address. And I think some examples, while we haven't spoken as much about air quality, I know our COG partners here are going to tell us that's absolutely, they have lots of data on the air quality piece of this. And I think Dr. Lockman's presentation about the housing, I just have had a conversation, and Dr. Bernard was on that with me, with partners in Fort Worth who are seeing the exact same thing here, there. And while we certainly want to work individually with apartment complexes, we know that we've got to take system approaches for that. And the data that you all are bringing together would be extremely powerful, I think, to be able to look at some regional solutions. So my question finally, just your thoughts on, as we identify, hopefully, some goals for the next year that we may collaborate on, how might we begin to think about integrating our data from the and the strengths that each group has, so we can get some regional to support regional initiatives. Thank you.
I'm going to take a stab at it. So because it's been a challenge getting data from different sources, from different systems. There are a lot of organizational priorities that don't necessarily align with sharing data. And there are the privacy laws. You can't just share your patient data with everyone. But we have made some inroads in trying to get some people together. And maybe some of the learnings from those would be helpful in like setting the ground to get started with those collaborations. One is something like this, creating a platform where we all speak the same language. We realize that we're all working towards the same goal. And that usually breaks down like half of the barriers. At least we have someone that we can talk to. And second is setting the framework for data sharing. Again, mindful of the fact that privacy concerns are going to be a major issue. So for instance, when we approach folks to work with them, if it's, let's say we're working with loss barriers, with Foremost, if their patient data are used for patient care, that's isolated. We cannot use that for anything else but patient care in their system. However, if in that MOU we have some language about being able to use aggregate de-identified data for more regional approaches so that we can actually incorporate those into things that are community oriented without being necessarily any privacy issues. Then we work through the framework for that data to be extracted from their system into the platform. Those are conversations that we have with lawyers, but again, they're fairly reasonable as long as you have the expertise to let them know how that works. That's how we work with the hospital council. Some data we take from the hospital council are purely identified. That is, I can see a patient and see how they work through different systems. But others, we just can't have them identified because we don't have the framework for that, right? If you don't have a provider-patient relationship with a patient, you need patient consent. We can't go about getting patient consent for 1 million people. So we need it de-identified. So if we have it de-identified to the point, and there are some criteria for that, then there's more willingness to share data. We had that, it took us years to break down that barrier with the hospital council, but now we actually get data from them. So I think one of the, like, while I'm hearing these two CHNA, Parkland and Cook Children's talking, I'm like, well, you know, it would be great to have one single platform where we can say, you know, children coming from census tract, whatever that Cook Children interviewed or other census tract responded at this level. That's what the CDC does, right? The CDC has it, but they have it at the county level. Here, we need it down to the census tract level. We have the information, it's just isolated in different systems. How can we bring those together? We're happy to help figure out a framework that doesn't break privacy rules. And that also preserves, of course, businesses, right? They have business rules to competition and whatnot. Make sure that we have that framework for win-win for everybody who's part of it without infringing on anyone else's individual priorities. But that's really an initial framework. I'm sure there's much more to it. I'll leave it up to.
Yeah, I think, you know, if there's any organization that will be able to use technology to push this forward, I have full confidence that PCCI will be able to do that. So I think that, you know, you kind of saw from the CHNA kind of how collaboration just organically started with Dallas County Health Department and PCCI. But I do think now, you know, with this summit that we've just had, I realized that, you know, and Parkland will want to collaborate with other organizations to have an effect on pediatric asthma. Now, I am hopeful that from this meeting here, we'll be able to have further talks about further collaborations that will take place. So I know for sure that Parkland will be interested in being able to collaborate more with other organizations, because, you know, we just came up about this just based on our own, you know, milieu of what we think needs to be done. But now we see broader perspectives of the tools and capabilities that are present at this meeting.
Well, I think they both just summed that up really nicely. No, I agree. And again, to highlight a little bit difference on the data that I shared and why it's a bit more easier for us to put that on a dashboard is it is that parent perception community aspect. And like they mentioned, when it comes to the clinical, the medical side of the data, we have to respect the privacy of the patients within our respective healthcare systems. And we have an ethic duty to share, but in a way that does protect those that come to us for treatment. So there are barriers, but as these two just mentioned, there's so much collaboration that can come to this in the future. And I think the more that we have meetings like this and summits like this, and we hear from how these different healthcare systems are working, we'll just be able to find collaborative solutions together. So.
Now, I do have to emphasize one of the big issues that we will have to work through a lot of the legal barriers and MOUs and things like that, and patient safety and, you know, patient information. So, but I think with, you know, if those things are taken care of, then we'll be able to collaborate well.
So does anybody else?
Oh, the voice one. Okay. So my name is Donna Hildebrand. I'm a medical director with WellPoint. And I agree. I think there's a lot of potential for collaboration. You talked in the Parkland project about the decrease in visits, in ER visits. Do you know which aspects of your program resulted in that? Was it the best practice alerts? Was it the asthma control program? Was it analyzed that all of these things were happening at the same time?
I think it would be hard, although I'd be confident that PCSA would be able to pinpoint exactly what it was. But I would think it would be all of those things
Okay.
that took place. One thing I didn't highlight is that we did create an asthma specific clinic in our and it wasn't a specific space for asthma clinic, but we are utilizing also respiratory therapists to do spirometry, and we're also using pharmacists to take the history for those patients that have asthma, and they'll spend 30 minutes to an hour getting a good history and also the education on asthma. And basically, they're just incorporated into the workflows of our pediatricians. So I don't have to spend as much time with education and also taking the history. So also that was another important part that I didn't put in our presentation. So I think all those things had
Okay,
a
that's
big
what I
part.
figured. That's what I figured.
And since we performed the analysis, we also were able to pinpoint, isolate the impact of the text messaging program, because that was probably the only program that you could split patients by. There were some patients who opted in, some who opted out.
Mhm.
But otherwise, if a patient was in the CHNA, they will be part of the program.
Okay.
We were able to analyze and see if there were any change in outpatient visits. In general, it wasn't all that impactful on the change in outpatient visits. The association between outpatient visits and easy visits wasn't statistically significant. However, the text messaging program in and of itself had a specific impact, improved the easy visit by 20 to 30%.
Okay, ours did too. Yeah, the text messages work for this population. I don't know why, but it does.
Exactly.
So my next question is clinical in nature. I feel like there's a lot of discussion about the use of controller meds, and the new pediatric asthma guidelines really get away from that. And I'm curious as if there are efforts to address that.
No, they don't get away from that. They don't. I promise, they don't.
Mhm.
I'm sorry. I'm the pediatric pulmonologist who really believes in the asthma guidelines, and it's supposed to be a controller and a reliever, right?
one medicine.
But it's one medicine that's harder to. Right. You can ask, are you using your asthma medication? And it's really challenging, I think, to track that particular data metric as we transition into the new asthma guidelines. But that's one of my questions. I would be interested if there were some data-driven ways that we could better track the use of the new asthma management guidelines.
Yes, we have incorporated the new medications, the combined medications in our asthma risk prediction model now and monitoring program, so we can definitely track how that use is affecting patient outcomes. Anecdotally, though, as a pediatrician, I do inpatient care currently at Children's, and I have to tell you, probably half of the children I've seen him come in with asthma exacerbations tried to follow those new guidelines and failed. Why? Because in part, you're asking parents to make a decision that even clinicians have a hard time making, deciding when they start giving their patients these combined reliever and controller medications. What it says is if a patient has symptoms, has a URI or whatnot, go ahead and get started with the combined medication and give it until who knows what the symptoms are relieved, and then you can stop. That alternative intermittent use is confusing everybody. We have half of the patients I've seen come in with asthma exacerbations. Parents tried to follow that and they failed. So I'm thinking it's going to be important either to educate patients to use it, or in the meantime, to make sure that what we know works, we keep using it until we have transitioned fully in these guidelines. I personally think maybe there was some level of underestimation of the complexity that it takes for folks to make that decision. Sometimes parents show, I'm like, what am I supposed to do? A child has a runny nose for 1 day. Do I start or don't I start the treatment? And when I start it and the runny nose stops, is it because I started the treatment or not? You see what I mean? So I'm thinking those guidelines I think it's going to be great. I think that's a great question, Shari. That is, we need to understand how they are impacting patients, whether the patients are taking the medications, whether they're taking it as prescribed. But again, I can tell you anecdotally, people are confused by those guidelines.
I agree with the ICS only. I think with the combination, we're having good results because we say use it whenever you need albuterol instead of albuterol, right? So that's very easy, and they get quick relief. It is very, very challenging with those smaller kids, and that's what most people are willing to start with. And I think that's what's hard. In our high risk asthma program, we're actually seeing pretty good results, but the difference is we have our asthma management people doing the education and all of that kind of stuff. And I think the biggest gap is the education that happens at the bedside or in the clinic, and that's really important.
Exactly. And we already have challenges with educating these patients for simple stuff, right? Now we're going to ask them to, but you're right. I mean, if a combination medication, because it's again a matter of take it when they have symptoms, stop it when they don't, right? And it's also a matter of a lot of patients that show up and they say, my child is doing fine. And you listen, you're like, this kid is wheezing. How come you think the child is doing fine? The patient themselves can't even evaluate that they're not doing fine. You are wheezing. You can't blow, like you have like a PEF of, I don't know, or PVC of like, I don't know, 60%. You are not doing well, but they've adapted to it. So they're doing fine. So sometimes it feels like, for some patient populations, it makes a lot more sense. And I'm not talking socioeconomic. I'm just talking people who have some level. Exactly. Sometimes it just makes sense to give them more structured, directive uh, treatment care plans rather than judgment driven ones.
So
No.
there is work to be done.
There is work to be done. I guess we got to wrap up.
I think we have the tools. I think we have the tools with the data that we have that we'll be able to see the outcomes and also compliance.
Yes, I agree.
So
And
I think it's
this
something
is
that we'll
another
be
thing
able
we
to
can
measure.
collaborate on. Yes.
Can I add to that real quick?
Well,
From the-
Savannah, it's lunchtime, but sure.
I will be really fast because I want to explain it from the non-clinical standpoint. Part of like the Center for Community Health is we're that bridge to gap once they go see their providers. Really now what happens once they leave that clinical setting? What's going on at home? What's going on in the environment? So when we work in conjunction with the clinical staff, we can help connect that dot. And that's why I really want to highlight the importance of a community health worker and that managed direct action plan. That person to connect with them. Hey, we notice you're coming back to the ER over and over. We want to see how we can help you. What's going on at home? What's going on? Are you able to access the care that you need? So really looking at it from that public health perspective of how can we treat asthma in our communities, working alongside our clinicians. As he mentioned, he has 15 minutes to meet with his patient. How are you supposed to address every social determinant barrier that they're going to hit once they leave that clinic? You can't. So it's about that collaboration, like we keep saying, the clinical, the public health, the different sectors in the community. I think that's where it really gets driven. And shout out CHWs again. Thank you for all your hard work.
Thank you. Yes. Yes, and that's a great segue. We'll break for lunch here in a minute. I'll pass it to Leslie for a few comments, but that will be the next part of our agenda today is to share more about what's happening in the community outside of a clinical setting. But thank you all for sharing.
Yes, let's have another round of applause for our wonderful speakers / panelists. Thank you. So before we take a small break for lunch, let's go ahead and answer our second word cloud question. So this question, in comparison to the previous question, will guide our breakout sessions this afternoon. So the question is in two parts. Again, same question. What 3 topics would you most want to discuss with other participants in breakout groups today? And of these 3, which is most important to you? Again, you can use some of the examples as your choices, or you can type in your own. And then again, we'll show the word cloud here during lunch. But as I mentioned, lunch is actually already ready for y'all in the back tables back here. So feel free to take a few minutes. I think we have about 10 to grab your lunch, come back to your seats, and then we can start our Community Voices panel. Thank you.
it's like, they're, they know how to check, they're able to do these, like, have to do I'm hearing a little bit about what it is, but yeah, because I'd like to. Yeah, because I know that's what I'm. So. And I'm either talk that matter. There's definitely because in the beginning I'm like mental. Okay. Like I say it so much in my head, and then I'm like. But hopefully that covers and explained well because hard to follow those two, but culture. Okay, good. Thank you. Thank you so much. Thank you.
Do it down to that motion. The education. I think that's fine. The provider. No, I will. Hey.
Oh, hey. Oh, okay, one. Right now, just
Let them focus on that.
Thanks for keeping your. Just the back to school event, I'm gonna be in Is that started?
So they're gonna go. Yeah, that's when they.
There's tomorrow.
Yeah. Yeah.
So I think, tomorrow is. Tomorrow's next. I need to go back to patients.
Yeah, I'll be here for most of it. Are there anything I can?
Yeah, but I think it'll be good now. So from perspective. Other.
Is there a way we could do?
I assume that they're gonna send it to us.
So to see his name up there, I didn't know.
No, I think they kind of found out about this last week.
Oh.
So basically what happened is, while you asked me to speak after death, and I didn't really know what was going on, and then separately asked. So had not informed her received it. She knows about it, but we had not fully like. I can definitely see, this is a big CHA deal, so. But yeah. No, but she knows on she.
Okay. That's Waldo. Yeah, I see that.
So Waldo's for Dallas County.
Yeah, right. And that's the pressure. But yeah, you gotta say, I'm meeting them in a month. Yeah, yeah. I mean, I think that's. And I have a 2-hour drive and I'm. Where it is? And I've been living in Texas. Oh, okay, all right. Valerie. At UT Tyler. Yeah. Oh, maybe some. Yeah, so the other, like, I help create parking. I don't even. Good. Like, yeah, coalition. How we have funding. No? Like, but they're all, and there are people who want it. Yeah. I can invent both. Funding. I don't know. Background. Right? Yeah, but then I'm happy to pressure. Best pressure is okay. Just say it. Yeah, see, everyone says that. Yeah. Oh, yeah. Oh, yeah. Okay, I'm gonna grab my, go ahead and talk about that. I think you're about to go on film. Oh, yeah, you are. I'm gonna grab my food real quick. Yeah, yeah.
Kevin, I'm gonna have to pay.
Okay. Okay.
I know you have to on the phone. Wait, conversation. Yes, I was embarrassed. I'm like, oh, that's so sweet. How could I not have met you? It's so nice to meet you. And thank you for the place.
That's good.
Yeah. Really appreciate it. Okay. It's very important to have professionals.
No, I understand, no problem.
Informal setting. It's one thing to sit and you can expect a good
Is it,
mingle with them, and then invite them and drink with them. I heard you saying that. I know that's old school.
But
Absolutely, they do. We don't prescribe that anymore.
We don't either. We don't either.
Maybe we should, yeah, exactly. Maybe we should think of that.
That's based on, I mean, I work with
Amazing.
somebody.
Yeah. I know way back then when they discharge patients, people had asthma, we would give them enzyme. Yeah. But I think in my days would be much less, like measurement.
Yeah. Oh, so the way I was.
Okay.
The older kids are taking.
Cool.
Exactly.
So that's why.
They stop.
Exactly.
Yeah.
They stay away.
And so they want like sort of,
Spirometric.
yeah, symptoms and so, but I think it does.
It would be, it has,
Yeah,
it has.
there's definitely kids that
Would be, like,
but it's really just.
I know, exactly. There's always a community perspective. You're like, this food is so good. It's not working in this
Talk to the parent.
And then you're like, yeah. Like, oh no.
And for the ones.
Yep.
That's.
I'm doing some work. Oh, right. I found out. What I did this. Their problems are. That's what I've been doing.
They don't know, and they don't think they don't know call.
That's right.
Because they, and I keep telling them, but I have a special population, right?
They show up, their problems.
They are not even following the actual for. Yes, very well. So usually when they don't do it, something has gone on. So I think the ones that are.
Industry as a whole.
That's
right. And we're talking. Hello, everyone. If I can have you come back to your seats, you can continue eating. And then I would also like to welcome our Community Voices panelists to come up. You will be sitting up here in the front seats so that we can start our next presentation. Okay. Okay. We all good? Okay. I think next we will be showcasing some of our wonderful community resources or community voices as well. So I will be switching the screens here in a little bit and to showcase our wonderful community resources and their information. But first, I want to introduce you to Dr. Sade Afolabi, who will be introducing our next panelist for the Community Voice and Perspectives panel.
Hi, good afternoon. Thank you all for joining us. I'm going to introduce you to our panelists. First, I'll introduce you to Shamara Norris. She's amazing. She is an executive director of Positive Breathing Organization, our Asthma Chasers. She's founder and executive director. It was established in 2011. Shamara is a registered respiratory therapist who specializes in adult critical care and emergency room too, right? Which is really challenging, and then focuses on children's respiratory care beginning in 2007. She was formerly an educator in a local respiratory therapy program, and she is known as the asthma lady in Dallas County communities and has partnerships with the city of Dallas, local hospitals, churches, nonprofits, and schools. And she does that bus that we all saw, right? That's very, very important in the community. And then I'll introduce you to Pam Rogers of Children's Health. Pam Rogers is a registered respiratory therapist with over 20 years of experience in healthcare administration, operations, and leadership in pediatric healthcare. She holds a master's degree in healthcare administration and a bachelor's in psychology. She's the senior director of disease management at Children's Health, including the asthma management program, which I would work with her with, and then she has a son with asthma too. Yes. Marquita Jones, she's program coordinator of the Healthy Homes Asthma Program at Cook's Children's Center for Community Health. She works to create asthma initiatives to promote healthier home environments for children and families with asthma, as Dr. Lockman talked about, how important mitigating those factors are. And then we have Courtney Bernard, Dr. Bernard. She is the director of child wellness at Cook Children's Center for Community Health. She oversees the development and implementation of community-based initiatives focused on improving the health and well-being of children and families across North Texas. And so I am here to ask you a couple of questions. First, we'll start with this introductory question. And so we'll start with Shamara. That tell us what is one of the what are some of your program goals? Who's eligible for those programs? And what is your overarching and what are some things that you think that this group can really glean from you to help improve their programs? I know it's a big question.
Our program goals are to educate. That was one of the main focuses of Positive Breathing, was to provide education to the community. Because what I noticed as a respiratory therapist in the hospital locally, a lot of families did not receive education. So really the hospital was their doctor. So anytime their child got sick, anytime their child experienced a symptom, they brought them to the ER. And so my question to them was, well, have you ever been educated about asthma? And majority were saying no. And so my focus when I first started in the community was education. We help children ages 5 to 18 because that's really when they like to diagnose kids with asthma, is at the age of 5 to 18 years of age. And it's easier to get children, and I hate to say it that way, but we live in a state of Texas, so it's easier to get children medical benefits if they can't afford it. And it's easier to help them receive care if they can't get it. And so that's the age, and anyone's eligible within our organization as long as you fit the 5 to 18 criteria. We do try to provide education, free asthma tools, which are nebulizers, spacers, mask, helping you get your machine fixed if it's broken, providing you a machine if you can't get it. And so that's what we do.
And that last question, which is the hardest question. So what do you think that this group can glean from kind of what you do in the community? What can we learn from you?
A parent, I guess, perspective, because I get to hear from the parents, because I don't work for a healthcare entity, right? I get to hear from the parents what they see at hospitals, how they feel about certain hospitals, what they feel like they haven't received from hospitals, what they feel like they haven't received from their doctors. And actually getting to hear what's really going on within their homes. You know, food insecurity, their landlord won't help them take care of the mold problem. They've talked to their landlord. The lady across the street, you know, did call and report the problem, and then they evicted her within 30 days because she complained, and now her family's homeless and they're looking for a place to, you know, just being able from the community perspective to get those answers and bring them to people that can make some decisions, can change policy, and make some changes within the community.
That's a really valuable perspective and really important. Thank you for all the work that you do. It's so important.
Thank you.
I'm going to move on to Pam Rogers. I'm going to ask you the same question. So what are your program goals? Who's eligible? What are some of the services? And then what do you feel like we all can kind of learn from your program?
Okay, good afternoon, everyone. Some of our program goals at Children's Health is, as always, decrease emergency room visits and increase hospitalizations, decrease missed days of school, keep them parents at work. Our overall goal is to keep kids where they're learning and playing at school. We want to make sure we educate the parents, the caregivers, the school nurses is a big part of our programming to make sure that the kids can stay at school. We want to improve their overall quality of life and, of course, their asthma control scores. We service anybody with a diagnosis of asthma. We get referrals from all over the county, and that's from their primary care, their doctors, schools, parents, nurses, wherever they refer into the program, we'll hook them up somewhere. We did a lot of in-home visits, but kind of retired some of those. So we do most of them virtually, but we do go out to the house. As Shamar said, social is so important. So if I can tell you, listen to the parents' cultural beliefs, listen to them because they are with their kids every day. And when you can partner with them, you can make a big, big difference. They want to pay for the medication, but they also got to pay to keep the lights on. All right. And so judgment is a big thing because they feel like they're going to get judged. So it's more of a partnership to get little things and baby steps to get them there for their kids to have better control. Now, there are some parents that don't want to partner, but there are a lot that have a competing priorities. And so when you see a snapshot of them at the hospital, it's so much more going on at home. Did I get them all?
Say that again.
Did I get all the questions?
Yes, you got all of the questions. And that is so important. Meeting parents and families where they're at is just invaluable. And I often try to do that, but it's challenging when you have 15 or 20 minutes to do that, which is why asthma management is so important. And Marquita Jones, I wanted to ask you the same questions. What's your program's goal? Who's eligible? And some of the program services, and what do you feel that we can learn from your program?
For the Healthy Homes Asthma, sorry. For the Healthy Homes Asthma Program, we focused on the environmental triggers with families. We do one-on-one home evaluations with the families. We actually do them over the phone. We speak to the families about the environmental triggers, helping them identify exactly what triggers are for each child. We want to make sure that the family understands what triggers are, whether they're at home, school, grandmother's house. We want to make sure that they identify those triggers and are able to advocate for themselves in different environments. I can let Courtney elaborate on our eligibility.
Sure. So Healthy Homes Asthma Program originated in 2016, and just like Pam and Shamara said, it really came out when we saw some of our internal patient data, seeing the high number of ED visits for asthma, indicating that kids are coming there for their asthma management. And then so this program was really born to address another side of the issue. We know our pediatricians are providing really great clinical care. We have asthma educators, pulmonologists doing their specialty care. And so when the Healthy Homes Asthma Program was born, that's where we focus on only just those home environments. So we're another part of the puzzle for Cook Children's patients. And so therefore, our eligibility criteria are limited at this point to Cook Children's patients or Cook Children's Health Plan members, pulling from our electronic medical record, the kiddos who are coming to the ED 3 or more times in the past year for asthma care for some kind of asthma reason. And then we've expanded that to look at those coming to urgent cares or our health plan members, looking at that claims data to see if they're going to other healthcare organizations, other EDs in North Texas. All of the
A little bit more about the actual program. It's a 3-month program where we speak with the families. We offer them asthma education as far as the environmental triggers. We offer them free supplies such as air purifiers, chemical-free cleaning supplies, bed and mattress encasements. We also provide services such as carpet cleaning, air duct cleaning, as well as pest control, because we all know pests can be a big problem within treating asthma. We also, the families that we don't get in touch with, we like to make sure that they still have that information. So we have information on our website. We have information about the environmental triggers as well as how to remediate them as much as we can without speaking to them. So we mail out information to those families that we are not able to reach.
Go ahead.
Well, I was going to say, I think to answer or to really narrow in the answer to the last question you asked all of us is, I'd echo what Shamara said is um, uh, there's always more behind what you see when you're looking at a family. There's always more. When I hear people in whether they're in a clinical setting or just a school setting, but wherever they're only looking at their one little area, and they say, "Well, why is this family not complying? Why aren't they doing what they're supposed to be doing?" There's always a reason. There's a whole story behind it, and that's what our programs really get to dive into. I would guess all of us here we have the luxury of building that relationship with the family and spending that time to hear what's going on and work with them one-on-one to move forward with
We
them.
work with community health workers. We use community health workers that establish those relationships in order to for the families to let us know that they're hungry and let us know that their lights are about to be turned off. And so we meet try to meet the holistic, the whole family. If they're hungry, if their lights are off, if they not understanding exactly how to do them, how to take their medication, we offer them asthma education. Our wonderful asthma educator Liz has videos that are very helpful for our families. So we like to share that information with them so that they understand each part.
That's so helpful and so valuable. It sounds like time is really important and spending a lot of time with families, at least, maybe over a longitudinal time, right? Because they don't always have that 2-3 hour block to really talk about things. But we were just talking kind of offline, Shamara, about the time in the clinic, right? And the time and the deluge of data that you can glean from the medical record, but don't have the time to get that information, which is where kind of this data information is really helpful and important from PCCI and from Parkland. And so I wanted to ask you, what are some ways, and I don't know if you have the answer to this, but what are some ways we can, one, streamline the data, and two, connect that data with what you're seeing in the house, like not at the bedside, but like literally at the home side. And I don't know if you have that answer or anybody has that answer, but
I think this group is going to be a way to streamline it because we need more collaborative thoughts, more collaborative input because working in the healthcare, I know doctors have 15 minutes with a patient, and there's certain things, like you said, that have to be documented on your behalf. Respiratory therapist sees the patient, and we have access to the information also, and we're able to see from an Epic computer standpoint where the patient has gone, whether it's a doctor's office or many hospitals within the community. But you can take all of that information and then you really don't have time to provide the education that the patient needs at the bedside because it's really about education. So I think if we all kind of come together and it's going to have to be an asthma education, whether it's in the school district. Maybe you can have an office set up at each school district. I mean, and it can be provided through the nurse. Well, yes, the nurse has other patients, but there needs to be a standalone only person to provide that care. Uh, I'm just looking at how can I reach that child, and it's school, right? All children have to go to school. They all have to, and the school district, somehow we need to pull them in and explain to them, this is a costly service to you all. If a child misses school, it costs $34 to $38 a day, whether you realize it. That's how much it costs if a child misses school. So if a kid is sick with asthma and they've missed 3 weeks of school, your district and your is losing money. You have to present it in a way where the district can see that it's costly, it saves them money, but it also at the end of the day, it's helping the child and the child's well-being.
yeah, I was going to say you're in schools too. So
I wanted to piggyback on that. We look at zip code data, and so we look at the top 10 zip codes. And if you overlay that with air quality, if you overlay that with economics and where they live, that's where we can all come together to essentially make life better for children, right? I sit on a lot of councils throughout the Metroplex, and that's where it is, that school, where their air quality is, and the hospital and the community getting in there. And that's how we can help each child from my perspective. What are the questions, Chad? Was that it?
That was the biggest question. Yeah. And then same thing. You do integrate data and bring it kind of to the families, but not fortunately or unfortunately, you're kind of limited to the health system and the health plan. Like, what are some lessons that you've learned that can be extended beyond that?
Mainly to that community health workers are invaluable. I believe that they have the time. Some of them are from the communities. They're able to engage with the families, and the families feel comfortable engaging with them. I believe that any corporation, any hospital, institution should have community health workers on their side, because that way you can have that one-on-one communication with the families. You're able to get the information to the families the way the families need it. You meet them where they are. And a lot of times we have special skills. Our community health workers are personable with families, and a lot of times we can get information to them the way they need it.
Can you explain a little bit more about community health workers? Because there's some learners here and that some other folks who don't know about what they do. Even me. I mean,
So community health workers are liaisons between the families and the hospitals or the physicians or the clinics. We are able to speak with the families, spend time with the families, and get more in-depth information on maybe those social determinants of health. We're able to help them fill out paperwork for Medicaid or fill out paper for food stamps. Because a lot of times if your child's asthma is not a issue at that moment, and you're hungry, we need someone to help them identify places that they can find food, or places that can help them with their rent. So I'm a great advocate for community health workers.
They're also, it's a statewide certification, so it's a recognized profession. They're also recognized nationally. Yes.
And how many community health workers does your program have?
Our Healthy Homes program has
5. Well, there's 5 of us. We have one that's just recently she left us, but she still can contribute to some of the information that we have for our families.
She still has input, right?
Yeah.
She's letting you know what's happening. Yeah.
Yeah. And throughout the Center for Community Health, we have 13, I believe. Right now, we have 13.
So this is just me being nosy. So if anybody else has any other questions, please. How many families do you think you're able to impact on like an annual basis?
We got some numbers here, but we last fiscal year we served about 350 families in some capacity. For that one-on-one care, our team was able to serve I think 120, 130 for that one-on-one prolonged
longitudinal program.
Mm-hmm.
And Pam, can I ask you the same question? You have respiratory therapists and nurses specifically.
I know you're about to ask me the question, and so I started going in my brain. So we have a 3 and 6 month program that services the Metroplex and the 7 surrounding counties. And every child that's discharged out of our facility, Plano and Dallas campus, gets an automatic referral into our program. With that being said, and we call everyone that leaves the emergency room that has came in as a wheezer or breather. We touch a whole lot of patients a year. And I'm going to throw a number out there that's probably underestimating, but my team probably touches 2,000 to 3,000, and that does not include what we do in schools and community. That is strictly from the hospital and our clinics. We do a lot of, and that goes back to the question previously, educating community practices. Everybody doesn't know how to manage asthma. And so we do a lot, and we target those zip codes. So we target the community practice, the school. And so sometimes we'll go and put a whole effort around a zip code and to see if our efforts indirectly or directly change the outcome of that area. So those are some things we do, but we touch a whole lot of kids throughout the year.
And how many folks are in your program?
Currently?
How many direct in your program?
So directly in the 3 and 6 month program a year, probably 1,000. Directly coming out the asthma at home from the hospital, not current because we're going down on asthma, but yearly, probably 1,500, 2,000. And then we call another 2,000 or so throughout the year. So a lot of kids. We have a team of 18 right now. So we have 5 inpatient asthma educators on both campuses. We have 4 nurses, 4 respiratory therapists, a couple social workers, and admin people.
Shamara, how many?
I'm gonna talk about how many devices we've given out so far this year. We've given out nebulizer kits, would include mask, about 454 to families in the community so far this year, and about 16 nebulizer machines that were broken, and we just replaced them.
That's a lot.
That's a lot.
That actually, that's a whole lot.
Where we partner with her, as y'all know, Medicaid only gives out so many. And then the schools ask us for some, and then that's where this partnership, can they have more, right? Because they're,
We don't ask for anything but a name and a zip code, and that's it. And an email, just to kind of follow up sometimes, but it's not, but 454 we've given out so far.
Wow.
Yeah.
So what I'm most impressed about is that you all really kind of work together. And I'm going to say
And
that,
I don't, whether we realize it or not, we really do.
yeah. You really, really work together and really work to advocate for the community. What are some lessons we can take from the collaborate? I know I'm asking these hard questions. I'm so sorry. But we need to move this we need to move this upstream, right?
Yeah.
You're at the community level. What are some policies we need? What are some interventions we need to move this to really have integrated, coordinated care for the whole community?
One policy that I was thinking of while I was sitting over in my seat, they were someone asked, who can write the asthma action plan? There's only one person that can write an asthma action plan, and that is a physician. And they only have 15 minutes to do that. And they don't have the time. And that really happens at administration level, not at the physician, because the physician would love to talk to you. They would love to find more detail, but they are being watched, they are being clocked, they are being evaluated on every little bit of thing that they do. And how do I know? Because I work in the healthcare field still. And so you get evaluated every year, and they tell you these things. Oh, you spent too much time charting. Oh, a treatment only takes 8 to 7 minutes. So I can imagine what they're being evaluated on at their level. So someone else has to be able to help write this asthma action plan. She said 37%, I think, asthma action plan. Do you know how big of a deficit that is? If a child has an asthma action plan, the parent actually can know, okay, rescue inhaler, okay, controller medication, okay, this is the steps that I need to do before I get to an emergency room. I can do at home. I can be proactive and take care of my child at home before I can even take them in. And so to put that much weight on a physician in 15 minutes is hard. It's difficult to do. So we need to advocate policy to allow maybe respiratory therapists, maybe community health workers, someone else beside the physician to write an asthma action plan.
I was sitting here thinking a lot. I'm gonna go from the parent perspective because I am a parent with a child with asthma as well. Inhalers are expensive. And so think about, when I go to the pharmacy and my child's inhaler is $70, I automatically think about other people that can't afford that. So I'm a proponent of stock albuterol in schools because so many schools come to us asking for how can we help them with medications, with spacers, because they don't have enough. If the parents only have one, they're not going to leave it at school. So when the kid gets sick at school, what is going to happen? That's a 911 call, right? Or that's a cup that they're going to try to use. So I would say from a policy perspective is how can we get more stuff in the schools to help out that? And then how can we make inhalers more affordable?
Girl, I'm talking.
So I'm going to just ask you all, and maybe Pam and Courtney in particular, I know Pam, you're doing some wonderful work with schools, and Courtney can speak to our work with the making stock albuterol available through the Asthma 411 program. And I think these partnerships are so critical. I hope it's just something we can consider. How do we connect our health systems better with those school systems where kids are spending so much of their time, and those frontline care providers who are nurses in the schools and are so overwhelmed. So we've heard that 37% of these kiddos don't have their asthma action plan. Even after all the years we've partnered with school districts over as part of Asthma 411, one of our districts last year reported to us that only 11% of children with current asthma had the asthma action plan reaching the school. So where those kiddos are is not where, even if it gets to the family, it's not getting to the school so that people who are there all day can help them. That's a critical area for improving our communications between health systems and schools and finding those ways to do it. So I'd love to hear, again, a little bit more about some of the different existing programs and partnerships that we have with schools. And then perhaps as we go forward, we could think about some potential solutions that will help with that communications. Thank you.
Yes, so I can speak a bit to the Asthma 411 initiative in Tarrant County. So Cook Children's is one of the partners along with Dr. Alsop's group at UNT Health Science Center and Safer Care Texas, and then others at JPS, an acclaimed physician group, network group. But our organizations come together to provide that stalk albuterol, to provide standard delegation orders, to provide the pharmacy services, to have that albuterol on hand at the schools at a district-wide level, to provide annual education to the school nurses and school health staff. We know not very many schools actually have a designated school nurse that is on campus all day, so that's another challenge. So we work together to provide this service year-round with our school partners. And to echo what Dr. Alsop was sharing, our kids are there a third of their time. They're in this school, so we obviously want those adults to be part of our team to surround the child. And we hear from some of our school health staff who participate with us when we ask them what are the challenges and barriers they face. And I think two that really stand out to me is one, they don't feel like they're considered part of the child's medical team.
Yep.
They don't feel respected in that. Communication barriers with data sharing, some of those structural barriers there. And then even from the parents' perspective, from the parents' attitude towards the school health staff person, being able to communicate back with the parents of what's going on with the child in school. So there's some big disconnects between where this child is moving in their community and in their world on a day-to-day basis. And those grown-ups are not talking to each other for the various reasons. And so that speaks back to the question you posed earlier, is how can we integrate data better? And with FERPA and HIPAA, there's some logistical challenges there to overcome.
In terms of the asthma action plan, which Shamar was talking about, what we try to do, the schools we go out to, we give them a generic one, and it's a magnet that we give to every school nurse to put on their cabinet. So you can at least know what to do in the different zones, even if you don't have a child's individual plan at the school. We're working right now, partnering with DISD head of nursing. Melissa was with us, Melanie or Melissa, I'm sorry, was with us last week at our conference, and we let clinicians ask her questions, and she asked questions. So when kids are discharged from the hospital, what does your nurses or MAs need at the school, and what do we need, so we can further that partnership with school nurses? But what my team does is we just sit and say, okay, what schools are we going to attack this year? All right. We go speak at all Region 10 conferences, which we speak this summer at a couple. And then from there, we hope that some of those schools say come. And then when we go, we give them spacers as they need it for their clinic or magnets. And then we go seek out schools, right? All around the Metroplex, we go seek them out. Let's see where we're getting these kids from, and let's go see if we can get into these schools on their professional development days.
Anybody else have any questions? Because we're just up here talking. Go ahead. Yes. Can you use your microphone? It's off. You got to press the speaker. Yeah, there you go.
Okay, I think I figured it out. I just want to put a plug in. I hear a lot of y'all talking about the schools. I sit on a board for a charter school. And so the ISDs are easy to connect, but also make sure you're talking to, consider talking to the Texas Charter Schools Associations, because a lot of these schools are representative of underserved students, underserved families. And so, and also you probably do not deal with a lot of the red tape that you'll deal with some of the ISDs. So Texas Charter Schools is one that's representative of all the schools across the state. That is something to consider.
Thank you for that feedback. That's really helpful. I agree about the asthma action plans. I think it's so important. And I think one thing we kind of forget is that our prescription is actually an asthma action plan, like our prescription for our, and yeah. Our prescription for our controller and for our inhaler needs to be an asthma action plan that somebody can easily fill out and educate. Yeah. There's an online question.
Yeah, we have a comment and then a question. So we have Lynn from the Asthma and Allergy Foundation of America. She said, such a great meeting today. So happy to be here. As a national patient advocacy organization, we have received many calls across the country from schools/districts that are now required to provide stock albuterol with new state laws. However, many of them are unfunded mandates. This leaves local ISDs and LEAs scrambling to fulfill these new med requirements without much guidance. Just sharing a national trend we see in case it's helpful for local advocacy efforts in Texas. And then we have a question from Diana Davila. She said, are there any resources in South Texas area?
Any resources in the South Texas area? That's a great question. I know that Driscoll Children's has resources, but I don't know if anybody else knows of any other resources. The only resource I know specifically is Driscoll Children's, and there's a respiratory therapist who's there specifically who is involved in their asthma management program.
And the only thing I can offer is we do have an app. It's Go to Children's Health is My Buddy, and it has asthma videos in English and Spanish and all how-tos that can help. But I don't.
And if I might just add, I mean, South Texas is covers so much territory, and I know there's a couple of coalitions in different areas. But if that individual could go ahead and, perhaps Karen give you that information, maybe we can follow up. I wanted to say, as far as that national initiative with the stock albuterol, I just can't pass by the opportunity to say, yes, it's critical. And yet, I think it's so important that we have that, so many benefits that it can be implemented in the kind of partnerships that are represented here today, because you have an opportunity then for that health system that has the resources and the health expertise to connect directly with those children where they are, and especially those kids who are falling out of care. So it's a wonderful thing to think about scaling this out on a broad basis, but where it's possible to do it within these partnerships, I think it has critical advantages. And I want to thank our partners at Cook Children's, and I'm really excited to hear the interest in Dallas ISD and our wonderful residents who have been working and advocating. Dr. Jamila.
I just had one question for the community health workers. Are you able to bill for the visits and the work that you do? Are you doing that now?
All of the services we have through the Healthy Homes Asthma Program where we utilize CHWs are free. It's all part of our community benefit.
No, actually, I meant, are you able to build insurance for the visits that you do?
Oh, I know. Well, we don't. Well, okay. So to extend my point there, no, because there are no charges. So we're not billing anything for the services we have through our work.
So I don't think, to answer that question, I don't think that's a billing and code
that's not up to date
charge. Yeah.
But I understand that it's now billable, isn't it?
It is billable. Yeah, that's the point. It is billable, but we haven't figured out. Like, we've talked about possibly billing, and we just haven't, because it's been free. It hasn't been a priority. But yeah, it's something that I think we need to work on.
I think UNT Health Science Center also has a community health center training, a community health worker training center, and they're working on that issue as well, making that billing so we can expand and scale those programs more efficiently.
I wanted to make a comment from a parent perspective, and this is regarding the asthma action plan. So when I send my kid to school and he has this wonderful treat combination therapy versus albuterol, the school nurse is not going to do it all the time. So I have a wonderful pulmonologist that will write for him to get albuterol at school. So if your parents come tell you that they're not doing that because they don't feel comfortable, get the kids what they need at school. That's a comment I can say from a parent perspective.
Yeah, no, I agree wholeheartedly, and we're trying to do the education, but it can be challenging even in our own ERs. It's challenging to do a new smart therapy. So, but it works.
It does work.
Weren't we with time?
I think we can give everyone some little lunchtime back. I know some of you, especially our panelists, are waiting to eat. So thank you. Let's give let's give them a round of applause. Thank you so much for the wonderful information you have shared. If you have not seen already, the screen that we're showing right now has all of the wonderful community resources with QR codes to their websites and their information. So please feel free. It's on rotation, so you'll see all of them. But please feel free to scan those from in person and at home. And then we'll take a small break before we go out to our breakout sessions. Thank you. Okay, everyone, if we can please take our seats, we're going to continue. We're going to start our breakout session for this evening. I realize I said evening and we are in the afternoon, but we're about to begin our breakout session for this afternoon. So again, I hope all of you have enjoyed everything you have learned and heard and the wonderful speakers you have heard from today. We are so grateful and thankful for them to be able to share that information with us and kind of see all of the data and then the implementation that goes into all that collection as well. So with all of the things we have learned in mind, we're going to start our breakout session. So from the word cloud results, these are our top choices from the audience in person and online. So we have indoor air quality, outdoor air quality, education, and access to healthcare as the top 4 choices. So we will divide into groups of 4. Each topic will be assigned a color as you see here. And if the people in person can see behind me, you will see the different colors in the little placards behind me. And they're each separated by groups 1 through 4. So you will go to your topic of choice. We want at least 6 people per group. So if you see your group is full and it has the 6 people, you can move on to your second favorite topic. And don't be discouraged if it's taken up. So each topic will be assigned a facilitator. And if you don't have a facilitator, you can do practice democracy and vote for one. One facilitator and one note taker in the group. So topic groups will answer the following questions. So 1, what are the most important priorities to address in each topic? Which one topic might be the best starting point to address this driver of asthma? What solutions might be first considered? And what are the goals for 2025? Again, I will leave these groups up here so that you all can start going towards the back of the room and finding your topic that you want to discuss. And then we will proceed with choosing a facilitator who can also be the note taker for that group. So if everyone here can start heading back. And then for our online people, if you hold on a second, I will guide you to what we will do online. Hello to our people online. Again, my name is Leslie Reyna, and I will be helping you facilitate the questions for our groups online. So again, if you weren't aware of the topics, we do have cultural barriers, lack of healthcare access, language barriers. I will type in the topics for you all online so you can see what the 4 chosen topics are. So these are the 4 topics that we will be discussing today. And these are the questions that we will be going over. So I want to ask each of you if you can type on in the chat, again, answering these questions. What are the most important priorities to address? What are the best starting points to address with this topic of asthma? What solutions might be first considered? And what are the goals for 2025? So we will start, of course, with the first topic. So if you want to type in the chat your responses to these questions for the first topic, please do so that we can engage in discussion. Okay, I see we have some answers to what are the most important priorities to address with this topic. We have legislation that requires proper indoor air quality measures in school districts, smoke-free policies across Texas. What other priorities do we feel are important when addressing the topic of indoor air quality?